Yes, Dr. Suyoga.
Yes. A very good evening to all the respected seniors and my dear friends. On behalf of ICOG, the academic wing of FOXY, I welcome all the office bearers of ICOG, respected Dr. Parag sir, ICOG chair, respected Sheila Mane madam, chairperson elect, Secretary Foxy and President Foxy, President Dr. Sunita Madam, Dr. Suvarna Khadilkar Madam, Secretary Foxy, Vice Chairperson of ICOG, Professor Ashok Kumar Sir, and Secretary ICOG, Dr. Sarita Madam. I also welcome all the conveners of this certification program, Dr. Lakshmi Shrikhande Madam, Dr. Meena Samant Madam, and Dr. Pratibha Singh Madam. At the outset, I would like to introduce Dr. Meena Samant Madam, who is the convener for today's workshop. So, Meena Samant Madam, she is Senior Consultant and Head of the Department at Kurji Holy Family Hospital, Patna, Bihar. She was the past President of Patna OBGY Society, past Secretary General ISUPAR, Chairperson Foxy Clinical Research Committee 2019 to 2022. She had received the Kamini Rao Oration in 2005.
Thank you, Dr. Pandit. I think
Yes.
that's more than enough.
Okay.
So good evening.
I would like Meena Madam to give the overview of today's program so that our delegates will know.
Thank you, Dr. Pandit, and a warm welcome to each and everyone present here today. Welcome to the second day of this very important AUP certificate course of ICOG, in which we're going to deal with both medical and surgical management of a palm coin. Yesterday, we had talked on all the basics, which was very, very interesting, attended by a huge number. And today, we promise is going to be equally interesting. And by the end of the program, I'm sure all of us are going to feel rejuvenated. And delegates, do not forget to take the post-test, which is just as important. But at the outset, I would like to invite our chairperson of the ICOG, Dr. Parag Binimale, for his welcome address, his word of wisdom. Unfortunately, Dr. Ashok is not able to join. We are very blessed and thankful to our president, Foxy, Dr. Sunita Tandulkar, who was here yesterday. But so over to Dr. Parag Binimale.
Thank you, Dr. Meena. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all on the second day. Let me appreciate the efforts put in by the conveners of this program, Dr. Lakshmi Shrikhande, past chair of ICOG, Dr. Meena Samant, who's our governing council member, and Dr. Pratibha Singh. Yesterday, we had some very, very interesting deliberations, and today's topics also are pretty interesting, and I'm eager to learn from all our learned faculty today. I'm happy to tell everyone that today we've crossed the registrations of a magic figure of 1,700. We hope that more and more people will log in and get themselves updated. So my best wishes for today. Happy learning, everyone. And thank you, Meena, for inviting me.
And we are fortunate to have with us Dr. Sheila Mane, who's the ICOG chair-elect.
Yes, Meena, enough. I think we'll proceed. Yeah. So, as Dr. Parag said, the importance of AUB is so much in everybody's practice, and that is seen here by seeing the number of people who have registered for this certification course. And Dr. Lakshmi, Dr. Meena, and Dr. Pratibha, thanks to you for coordinating and structuring such a wonderful program. Okay, so all of us, we know that AUB is a very, very important topic, and in gynec practice, I think it covers everything when we talk about palm coin. And I think today we have so many speakers who are going to talk about all this, each thing in the palm coin. Like we have Dr. Pragya, then Damodar, Dr. Achla Batra, Ashwath, and so many people like Kiran, Abha, and Vishwas. And I'm sure that everybody will be benefited, because each and every aspect of AUB will be discussed or deliberated in detail and which will be of a great help. And I think all of us, you know, that even if you miss any talk or anything, all the certificate courses recordings are available on the website. So people can go and check there also, suppose if you have missed something. So once again, I thank Dr. Parag and the team of this AUB certificate course for giving me this opportunity. And thank you. Over to you, Meena.
Thank you, ma'am. And Dr. Sarita Bhali Rao, a very dynamic secretary of ICOG is here. Ma'am, can we just have it for you as well?
Thank you, Dr. Meena. Thank you. And I must congratulate Dr. Lakshmi Shrikande, Dr. Meena, and Dr. Pratibha. Yesterday was really fantastic with many, many lovely talks and practical take-home tips on this subject. And that's how we've had this overwhelming response. So really congratulations. And before I end, I'd like to say that applications for the fellowship FI
Neelima, her network is poor. You can post that link in the chat box.
we
FIC.
are online. Last date is September end. The next convocation. So I request everybody to please go. We will do that if it.
So yes, we have to register those who are not FICOG, they should, as Madam has said. So over to our conveners. I think we have a long program today, not long, but very interesting. So we should not get into that time. So here are the instructions for all participants about post-test MCQ test. So attendance for all 3 days course is compulsory. The link of the MCQ will be sent in the chat box, so don't miss out. Those who have attended all 3 days course passed with 50% marks on each day, they only will get the certificate from ICOG. Certificate will be sent within 1 month, so don't get panicked. Please note that this online certificate is just an acknowledgement of attendance. Practice depends on the skills and experience which we do not certify. So we do not enforce any skills of the attendees. The videos will be put on the ICOG website. In due course, for the course material and equipment details, you may communicate with the course coordinators. So this is from Dr. Parag Vinimale, Dr. Ashok Kumar, and Dr. Sarita Bhali, the office bearers of ICOG. So I think now we should start over to our coordinator, Dr. Panat. Can I have a CV? So Dr. Siyoga Panat, no, but we should all should know a little bit about you. Consultant obstetrician gynecologist, fellowship in advanced ART, past president of Amravati Obstetrics and Gynae Society, chairperson MOX Medical Legal Committee 24-26, and West Zone coordinators, and many accolades to her credit. Over to you, Dr. Siyoga Panat.
Yes, ma'am. Thank you, madam. We begin with the first session of today's certification course. And for this session, we have Dr. Ashok Kumar Todani sir, Dr. Lakshmi madam, and Dr. Tarini Taneja madam as the chairpersons. And we have 3 speakers, Dr. Pratya Mishra, Dr. Parikshit Tam sir, and Dr. Damodar Rao sir. So I would like to introduce Dr. Ashok Kumar sir. He was the past secretary and president of Durgapur OBGYN Society of FOXI, national faculty at AICOG for 17 years. He has won the Dr. C.S. Dawn Prize at AICOG in 1990. He has delivered many lectures as a faculty and has many publications to his credit. He is a faculty at Vagina Surgery Workshop since many years, and he has operated NDVH live at AICOG Bhubaneswar. He was the ex-vice dean of Indian College of Medical Ultrasound. So I welcome sir. Our next chairperson is Dr. Lakshmi madam. She is the former professor department of OBGY at Government Medical College in Kozhikode. And she is affiliated to many organizations, like she's the chairperson of the Educational Committee of IMS 25 to 27, President Calicut OBGY Society 23 to 25, immediate past president Calicut Menopause Society, Vice President of Calicut OBGY Society, and Honorary Secretary of Calicut Menopause Society, and so on. She was the organizing secretary of the 28th National Conference of IMS COP 2023 and peer reviewer of the Journal of Midlife Health. She has been awarded the WHO Fellowship in 2019. She has special interest in high-risk obstetrics and fetal medicine. I welcome Madam. Our next chairperson is Dr. Tarini Tarneja Madam. She is a gynec consultant, laparoscopics and IVF specialist at Tarneja Hospital and IVF Center, Delhi and Muzaffarnagar. She is the chairperson of ISPAT Delhi State, vice president of South Delhi IMA and president of Manzil-e-Rahat NGO. She has received many awards and achievements. She FIGO Breast Committee member, Bharat Gaurav Samman awardee, Foxy Chairperson Breast Committee 2018 to 2021, President of UPCOG and Chairperson of Delhi SR. She is the Foxy President Lifetime Achievement Award, Foxy Legend of Gynecology, and Isaac Dronacharya, Wonder and Proud Foxian, APJ Abdul Kalam Excellence Award, and so on. Special mention of the Nari Gaurav Award, Mother Teresa Award by Lioness, and many more to her credit. She has many publications also. I would request the chairpersons to kindly introduce our speakers so that we can go ahead with the session. Our first speaker is Dr. Pratya Mishra, madam. So I would request Dr. Ashok Kumar sir to kindly introduce her.
Yeah. I'm fortunate to introduce Dr. Pragya Mishra Chaudhary, madam. She is MRCOG, FRCOG, PhD, DFFP, FICOG, Diploma in Gynae Endoscopy from Kiel, and FACOG. She is consultant infertility specialist as New Life Test Tube Baby Center and MGM Hospital and Research Center Private Limited, Patna. She was President Patna Obs and Gynae Society 2025-26, Secretary General ISOPAR 22-24 and 24-26, and ICOG Governing Council Member 24-25. Chairperson Genetic and Fetal Medicine Committee, Foxy 2016 to 2018. Founder Secretary of Bihar Chapter of ISAR, RCOG Co-opted East Zone Fellow Representative 25-27, Examiner for MRCOG Clinical Examination, imparts Foxy Certified Colposcopy Training, awarded Asia GCC Award 2021 for Excellence and Leadership in IVF, Gynecology and Obstetrics. She has got lots of awards like Heathrow Healthcare Professional, then George Mahoney Award, then Dr. C.L. Javeri Award, Dr. Jagdishwari Mishra Gold Medal, the 18th and 20th Boxcon, and MP John Gold Medal in Organizing Secretary 10th National Yuva ISAR 2024 and Organizing Secretary of Foxy LaborCon 2023 at Patna, Organizing Secretary Foxy ISPAT GameCon. I'm lucky to introduce her. She will talk about abnormal uterine bleeding of polyp origin. Welcome, Dr. Pragya Mishra, please.
Thank you so much, Dr. Tudani, for the kind, generous, and elaborate introduction. I wanted to stop you, but I saw that we were on time. So at the outset, I would like to thank ICOG Chair, Dr. Parag Biniwale, and the Secretary, Dr. Sarita Balerao, and immediate past Chair, Dr. Lakshmi Shrikande, then all the conveners of this ICOG certification course, my friend, Dr. Meena Saman, Dr. Pratibha Singh, and I think I'm missing out on someone. So I'll just start sharing my screen. Every time the time comes to share my screen, I get very nervous, hoping that nothing goes wrong. So it's opening up. It's it says you are screen sharing. So yeah. So I think you can see my screen now.
Yes,
Correct? Yeah.
we can see.
Yes.
We can
So,
hear you.
yeah. I know it's a very intensive course, and it's AUB, and that too specifically talking about polyp in AUB. And I've been told to speak on presentation, diagnosis, and hysteroscopic management. So now, just quickly, I know a lot would have been said yesterday also, but it's important to start with the definition. And as you know, that uterine polyps are focal endometrial outgrowths that can occur anywhere within the uterine cavity, and they contain a variable amount of glands, stroma, and blood vessels, the relative amounts of which influence their visual appearance at hysteroscopy. Now, polyps may be soft and cystic, or firm and fibrous, sometimes confusing you with a fibroid polyp or a submucous fibroid. Now, they may be pedunculated or sessile, single or multiple. Oh, what's happened?
It's
can hear
visible,
you.
madam. It's seen, madam.
Your slides are not moving, Pragya?
No, no, from on my end, it suddenly disappeared.
No. Acha, we can see, but I think your network is having some problem then.
No, no, no. Suddenly it's gone. I mean,
So just you stop share and share again.
stop share. No, no, but it's there, but
मैम
Hold on
आपको
for the
स्लाइड्स
next
दिख
slide.
रहा है?
नहीं, वो बंद हो गया मेरा, मतलब नहीं दिख रहा है.
आपको शो नहीं हो रहा है वहां पे, तो आप एक बार
नहीं,
फिर से उसको आप ये शेयर करिए.
stop share and then
हाँ, स्टॉप शेयर करके फिर से शेयर कीजिए मैम. आपका इंटरनेट में भी स्लो है.
हाँ, सीरियसली स्लो है तुम्हारा.
हाँ.
Coming.
yeah, it says a resume slideshow.
Yes, ma'am.
You can switch off your video, Pragya.
I think again, actually, I was just trying to move that.
मैम स्लाइड को क्लिक कीजिए एक बार और फिर मूव कीजिए.
पेज डाउन करिए, पेज डाउन.
No, I think now you can see now.
Yes, we can see.
Okay, fine. I'll just
You can see the
fine.
first slide
Now,
of definition.
yes. So it varies in size from small with minimal uterine cavity distortion to large, filling the whole cavity. So now attempts are being made to produce a practical and reproducible subcategorization system of even the AUB P category within the palm-quern nomenclature. Now, the developing system based on features such as the number, size, shape, location, composition, and vascularity of polyps will help with associating the type of polyp found in association with particular AUB presentation. So, which means, if this is developed, then even we know that this presentation, which means whether it's in intermenstrual bleeding or it's menorrhagia or it's postmenopausal bleeding, so with which kind of polyp we may be able to associate. Now, etiology is multifactorial. In premenopausal women, a decrease in the levels of estrogen and progesterone receptors within polyp stromal cells may make polyps less sensitive to cyclical hormonal changes. And that's why, they don't go away so easily. And increased cell longevity may also play a role in the genesis of polyps as a result of inhibition of apoptosis and altered gene expression. Now, the prevalence of uterine polyps in a general adult female population without AUB is generally estimated to be approximately 10 to 15%, but with AUB, the prevalence of endometrial polyps is considered to be quite high, between 20 and 30%. And uterine polyps affect premenopausal and postmenopausal women with AUB, and indeed the prevalence may be increased after the menopause. Now, polyps can present with all forms of AUB, namely heavy menstrual bleeding, intermenstrual bleeding, and postmenopausal bleeding. And their causality has been inferred from the effect of removing polyps on bleeding symptoms, which means, once polyps are removed, there is actually the symptoms also resolved. So there is a good causal relationship between the presence of polyps and AUB, and alleviation or improvement in AUB symptoms is generally observed following polypectomy at follow-up intervals of between 2 and 52 months. Now, most uterine polyps will persist if left untreated, although small polyps spontaneously regress. Then risk factors for malignancy within uterine polyps include AUB, increasing age, postmenopausal status, obesity, diabetes, and increased polyp size and tamoxifen administration. The role of HRT is unclear, and the majority of uterine polyps are benign. Endometrial hyperplasia without atypia, the rates are between 0.2% and 22% in polyps, and the prevalence of pre-malignant atypical endometrial hyperplasia appears to be lower, with estimates in primary studies ranging from 1% to 3%. Now, definition of an endometrial polyp, based on all these diagnostic features, like on hysteroscopy, what do we see? Like a discrete outgrowth of the endometrium attached by a pedicel which moves with the flow of the distensional medium, and polyps may be pedunculated or sessile, single or multiple, and very inside. Now, on ultrasound, what you would find a non-specific endometrial thickening or a focal mass identified as an echogenic lesion, which disturbs the midline endometrial echo but does not disrupt the interface between the myometrium and endometrium. The lesion is usually oval shaped with a homogeneous structure, although hypoechoic cystic spaces may be seen. But I basically I've rarely missed out any polyp on ultrasound. It's quite easy to diagnose a polyp on transvaginal ultrasound scan. Now, blood flow may be identified within a feeding vessel extending to the polyp on color flow Doppler imaging, and saline infusion sonography and 3D ultrasound help delineate the borders of the intracavity lesion. On HSG, what you would find filling defects within the uterine cavity, and on MRI, well, Dr. Sonal Panchal spoke in details about it yesterday, iso-intense or hypo-intense masses within the uterine cavity, and contrast enhancement with gadolinium can show either homogeneous or heterogeneous enhancement. So histology, again, I think it was dealt in quite detail yesterday. So coming in to the diagnosis in details, now with plain transvaginal ultrasound scan, I just mentioned that a polyp appears as endometrial thickening, or with the more typical appearance of a hyperechoic lesion within the uterine cavity with the regular contour and surrounded by a thin hyperechoic halo. So transvaginal ultrasound is more accurate when performed in the proliferative phase of the menstrual cycle, and polyp size should be assessed at the time of ultrasound, as this can provide vital information useful in aiding management. An increase in the diameter of the polyp appears to correlate with risk of malignancy, with smaller polyps being more likely to resolve spontaneously. Many a times what I have seen that, if a postmenopausal, on a postmenopausal lady, if I do hysteroscopy who has presented with bleeding, and if I find a polyp, it's usually large. I rarely find small polyps. Small polyps are mostly found in premenopausal and postmenopausal, because many a times, it can be malignant also. So that's why, polyp size is very important. and it helps in aiding management. Now, color flow Doppler is useful in demonstrating the single feeding vessel observed along with endometrial polyps. And PAR Doppler, it gives more clue to the vascularity, which has been shown to improve diagnostic accuracy when assessing endometrial polyps in both asymptomatic and symptomatic women. And 3D has been used for assessing the endometrium, but showed limited improvement in diagnosis compared with 2D, although this is slightly improved with the addition of intrauterine contrast. Now, saline infusion sonography or gel installation sonography may be used to improve the diagnostic accuracy compared with transvaginal ultrasound alone. And by using saline infusion sonography, the fluid allows better contrast within the endometrial cavity, allowing for delineation of the base or the stalk of the polyp and improving detection of smaller polyps, which may have been missed by transvaginal ultrasound alone. Now, saline infusion sonography simultaneously allows the assessment of other pelvic structures, including the adnexa and myometrium, as well as the uterine cavity and tubal patency, and provides a useful adjunct to transvaginal ultrasound, especially when assessing patients' preoperative status to decide on the procedure most likely to benefit the patient. But somehow I feel that this SIS is still not so popular compared to other modes of diagnosis of a polyp. Now, hysteroscopy is the gold standard investigation for diagnosis of endometrial polyps, and it is hysteroscopy and guided biopsy. The risk of serious complications is quite less, with 2 in 1,000 women. Now, the advantages of hysteroscopy, well, it allows the practitioner to directly visualize the endometrium and simultaneously remove any polyps for histological diagnosis, saves the patient from returning for treatment, detect other endometrial pathology such as submucosal fibroids, which may also be treated simultaneously or assessed for further treatment. Performed in the outpatient setting with greater patient satisfaction with high success rates of up to 96% and high accuracy of the test in malignant and pre-malignant endometrial disease based on a large systematic review and meta-analysis of hysteroscopy. What about endometrial biopsy? Well, it can...
Sorry to interrupt you, ma'am.
Yeah, but I lost a little bit of time. So if you
Yeah,
can give me some
ma'am,
time.
1 or 2 minutes we can.
Oh, so I'll have to miss out the whole on the treatment. So blind sampling of the endometrium using miniature aspiration devices, being based on the pipple biopsy prototype or traditional DNC, frequently miss, but these blind DNCs, they frequently miss polyps, particularly if small or pedunculated, and makes histological diagnosis more difficult because of the tissue fragmentation. I never ever do a blind DNC. Histology is also unable to confirm that the polyp has been removed at the base, and therefore blind biopsy should not be used as a diagnostic test when investigating for endometrial polyps. Now, treatment, we have expectant management, medical management, surgical, in which we have blind polypectomy. Again, I would never recommend, and hysteroscopic uterine polypectomy, but I had been told only to speak on hysteroscopic uterine polypectomy, so I just speak a couple, 1 or 2 minutes. Now, uterine polyps can be removed by excision or avulsion using a variety of fine mechanical instruments in isolation or combination, and such ancillary instruments include reusable scissors, biopsy cups, forceps, and disposable polyp snares. The safety, feasibility, and efficiency of such approaches have been well reported, and in general, hysteroscopic polypectomy using small diameter mechanical instruments should be limited to smaller glandular polyps. These are some mechanical instruments which are used while doing hysteroscopic polypectomy. Now, the drawbacks are that fragility of the instruments precludes the excision or avulsion of large or fibrous polyps, and bleeding may occur. The limited degree of movement of these instruments can also limit feasibility. The diameter of the cervical canal relative to the excised polyp creates challenges to removing pathology, as polyp tissue may slip from the small diameter grasping forceps when attempting retrieval down the endocervical canal. So recourse to blind retrieval of a detached polyp using standard polyp forceps should not be attempted routinely because the risks of uterine and intra-abdominal trauma are not insignificant, especially if the procedure is to be performed under GA. So that's where, we enter. And most of the larger polyps, one needs electrosurgical energy for hysteroscopic polypectomy. So the application of electricity has enhanced the cutting potential of hysteroscopic instruments, thereby overcoming the limitations of fine mechanical instruments, namely the removal of larger and more fibrous polyps. So large diameter hysteroscopic resectoscopes can be used under GA or conscious sedation, and the resecting loop can be used to remove the polyp in strips with repeated passes of the cutting loop, or en bloc by cutting the base of the polyp where it adjoins the uterine side wall. So most favored the efficient en bloc electrosurgical removal of a polyp
And
by detaching. Yeah, last slide, finishing. Detaching it directly from its base, but where larger or fibrous polyps are identified, and then piecemeal removal by cutting several strips of tissue may be preferable because difficulty with retrieval from the uterine cavity can be anticipated. So basically what I want to say that you may not always succeed in just doing a simple by the use of mechanical scissors or a polyp forceps, because many a times these polyps are large and one has to take recourse to electrosurgical cutting of these polyps. So thank you so much for a very patient listening. And I think I lost a little bit of time because of the problem with the internet or whatever. So I think
thank you.
Thank you, Dr. Pratya Mishra, for your nice deliberation. You have covered most of the parts, since both ultrasound and hysteroscopy has become our eyes, and ultrasound is more widely available than hysteroscopy. So we can rely now nicely on sonohysterography. Thanks a lot. We can move on to the next speaker,
I
please.
skipped one slide where it says that transvaginal ultrasound has very good sensitivity and a very high positive predictive value. So really, I mean, TVS is good enough. So even we don't even need 3D for diagnosing polyps. So I think that's what I could cover in 15 minutes, AUBP. And thank you once
Thank you very
again,
much.
Dr. Lakshmi Shrikande,
Thank you.
for giving this opportunity. And, also time to, the ICOG staff, which is working so hard, especially in Nilima. So thank you for your efforts.
Thank you, madam. Thank you so much. Now I would request Dr. Lakshmi madam to introduce Dr. Parichit Tansar for the second talk.
Good evening, everyone. At the outset, I would like to extend my sincere thanks to this entire team of Foxy ICOG certificate course, especially Dr. Lakshmi Shrikande for giving me this wonderful opportunity to be a part. And it's my pleasure to introduce Dr. Parikshit Tank. I think he has joined. He was requesting for 2 minutes.
Yes, I'm here.
Yeah. Hello, sir. It's
Hi,
my pleasure
hi.
to introduce you. He's a consultant at Ashwini Maternity Surgical Hospital and Center for Endoscopy and Assisted Reproduction, and also a consultant in Jupiter Hospital, honorary professor, an excellent teacher, and a postgraduate teacher and examiner. He's also the examiner for MRCOG Part 3. He's the managing committee member, Mumbai Obstetrics and Gynecological Society. He has several awards and publications to his credit, like the K. Bhaskar Rao Gold Medal for the first place, the DNB, the Kamini Rao Yuva Foxy Orator Award. And he has also co-authored several books in obstetrics, and he's on the editorial board of 4 indexed journals. Over to you for your talk on adenomyosis.
Thank you, Dr. Lakshmi. And
Hi.
Today there is lots of wealth in this webinar because we have two Lakshmis at least here with us. So thank you, Dr. Shikhande, for the kind invitation. And it's always a pleasure to participate in these ICOG courses because they are so focused and well directed that they really cover a particular subject in its great depth. So it's a pleasure to be a part of today's program. My thanks to Dr. Biniwale. As the ICOG chair, he has kept up these wonderful activities that ICOG does. Uh, I request the technical team to please share my PowerPoint. I think you might have received it from Nilima. I'm in a zone where the connectivity is not that great. So as soon as the slide share comes on, I'm going to switch off my video so that I can deliver this talk without interruptions. Tech team, requesting you to please. Yeah.
And
Okay. Thank you.
there's
Perfect.
in the chat box.
Yeah.
Yeah. Okay. Thank you, Nilima. Thank you for the backup. I'm just switching off my video. Yeah. So this is one of the important aspects about why AOB happens, the different clinical scenarios that one could get into, and it's one of the important reasons that we need to be looking at when we look at AUB as a whole. Next slide, please. So for quite a while, we wondered whether AUB, adenomyosis, what is the relationship between these two? Next slide, please. About 20 years ago, there was the study which was published looking at the histopathology reports of hysterectomized women. And these were postmenopausal women. And it was thought about, click please, that is adenomyosis, which is so very prevalent, so common, is it just a variant or is it really a disease? Because it seems to be there along with the other pathologies like fibroids, endometriosis, hysterectomies done for pelvic plane, etc., etc. So, is this an entity that really has pathogenic significance, or is it something that just happens in nature and we may overinterpret it as a finding? Next, please. Over a period of time, we also know that a substantial number of women will have adenomyosis but remain asymptomatic. We don't know exactly why that happens. Click. Next, please. And there is some gap in our understanding as to where we stand with AUB and adenomyosis. Sometimes it's the only possible explanation that we can give for AUB, and sometimes AUB is just a coincidental finding which may mask the actual etiology of the AUB. Next, please. So as Sir Norman Jeffcoat put it, the diagnosis of what they used to call it DUB in those times, and we now call it AUB, depends on what is the definition and what is interpreted as an organic lesion, and on the care and trouble that is taken to exclude such a lesion. So, adenomyosis diagnosis is a very important step in defining who goes into which group as far as AUB is concerned. Next, please. So our standard diagnostic approach is going to be, history, looking at the history in terms of the typical menstrual pattern and associated complaints, and examination, and our diagnostic tools, specifically ultrasound, that is 3D, preferably in the modern world, and MRI. Next, please. So, when we look at symptomatology and when we talk about history, that's what it's all about. The hallmark feature of adenomyosis related AUB is going to be the accompanying pain. Dysmenorrhea is typically sharp, cramping pelvic pain, and it is worst during the period. Now, this is a little different from congestive dysmenorrhea. In congestive dysmenorrhea, until the point that the period starts, the pain is bad. And once the period begins, the pain reduces. This is different from that kind of a situation. Along with this typical dysmenorrhea, there may be pelvic pain, which may be chronic. So there's chronic pelvic pain. There may be associated dyspareunia, dysgenesia also. And the woman may have a fertility issue as well. So this is the entire symptomatology that we are looking at. Next, please. And if we were to examine this woman, you usually find that the uterus is bulky, a little bit enlarged, not as enlarged as what we see sometimes with large fibroids. So typically, the uterus reaches about 12 to 14 weeks in size, usually smaller than that. The uterine movements and the uterine palpation is tender, and pelvic mobility may be restricted because of adhesions which may be there from the associated endometriosis. Next, please. When we look at imaging, there are basically two modalities that we are seeing. One is ultrasound, which is omnipresent, omni available, and the transvaginal route with a 3D is the preferred first line imaging technique that we are going to use. MRI, if there is some diagnostic doubt or if a TVS is not possible, sometimes findings of ultrasound, especially with lower resolution machines, might not be able to distinguish between fibroids and adenomyomas. And if you want to operate and want a good surgical mapping, that's where I would employ MRI. Otherwise, in with good modern ultrasound machines, that's the real imaging that we are looking at. Next, please. So the real change in terms of adenomyosis definition on ultrasound came with this consensus, which was the morphological uterine sonographic assessment, that is MUSA features. And this was an elaborate terminology which was used to identify what experts would call adenomyosis. So just to quickly take everyone through these, next please. There are certain direct features, that is the presence of myometrial cysts, hyperechogenic islands, and echogenic subendometrial lines and buds, which are the direct features. And indirect features are an asymmetrical thickening, that means the posterior myometrium being much thicker than the anterior, fan shaped shadowing, or what is called the Venetian blind uterus, a big globular uterus, translesional vascularity, interrupted junctional zone, or an irregular junctional zone. So these are the features or the MUSA assessment that we need to be looking at in terms of adenomyosis diagnosis. Next, please. Just a few examples to illustrate these. We are all quite familiar. The globular enlarged uterus, myometrial cyst, the interrupted lining of the endometrial zone, and the Venetian blinds that you can see on the posterior myometrium shadowing are what typically define the adenomyosis look. Next, please. So what can we do once we have diagnosed that this AUB is because of adenomyosis? Reassurance, I have mentioned it here because sometimes there may be some findings of adenomyosis in an otherwise asymptomatic woman or a woman who has very few symptoms. In that case, the adenomyosis itself need not directly be addressed or treated. Then comes medications, ablative procedures, and lastly, of course, surgery. Next, please. When we look at the therapeutic choices as far as medical agents are concerned, you have the standard ones, the COX inhibitors, gonadal steroids, either in the form of COCs, progestins, danazol, very less used now, but maybe Dynogest could be a alternative. And the local therapy, that is LNG-IUS. Then you have the GnRH analogs and receptor modulators and aromatase inhibitors. Next, please. But today, practically speaking, when we look at medical therapies, You have the GnRH analogs, which should be administered for 3 to 6 months. They bring about a shrinkage of uterine volume and the size of the adenomyoma, and there is definitely an improvement in symptoms. But we have to acknowledge that this effect is temporary. A few months after the GnRH analogs are stopped, the uterine size comes back to where it was, and the symptomatology also will resume. It's useful for women who are seeking fertility to get a temporary respite from symptoms and also to suppress adenomyotic activity to improve the chance of implantation. So, between an ovum pickup and a freezol, and then the thaw ET, you're going to give 2 or 3 doses of the GnRH depot to reduce the uterine size and reduce the adenomyotic activity to enhance the chances of implantation. Next, please. But if you look at a little more chronic kind of medical therapy, today the best therapy that we have is the LNGIUS. Next, please. So here you can see this is a single arm study. Click, please. Where we can definitely see a reduction in, click, please, in the uterine volume, in the pain score, as well as the PBAC score. So definitely LNG-IUS has a big role, even compared to COCs. LNG-IUS scores over it, and therefore that's the modality of choice when we are looking to treat AUB adenomyosis on a long-term or a chronic basis. Next, please. Next, please. Next, please. Next. So again, long term, that means more than 3 years, studies have also been undertaken where there is a significant and sustained reduction in dysmenorrhea. This study looked at the quality of life and found, next please, that the insertion of an LNG IUS system and compared it to a hysterectomy. And what they found, next please, is that the LNG IUS and hysterectomy group, they had the same impact on the improvement in the quality of life. Next, please. So imagine, next, please. So imagine the ease with which the symptomatology of adenomyosis can be managed. So continuation rates of are very high in this group, more than 97%. Next, please. Next, please. When we talk about surgeries, of course, hysterectomy is always there as the last resort, but we are increasingly talking about the adenomyomectomy. Now, this is a surgery, next please, which has been talked about a lot, and there are variations in the way how this surgery can be done. Either just the removal of the adenoma, wide excision, or removal of large parts of the myometrium. Yes, 1 minute, please. Next, please. This surgery is really easier said than done. And Osada is the pioneer of this technique. Next, please. Next. It does bring about a lot of symptomatic relief. Uterine artery embolization studied, but not a very favorable response in the long term. Next. What we are increasingly finding is talk about microwave ablation, and now this is being done under ultrasound guidance. Next, please. There are some studies which talk about it favorably. However, the current state of literature is that we don't have a very uniform protocol or a standard modality of doing this, and therefore long-term outcomes will vary according to how the procedure has been performed. Next, please. So AUBA is really a test of rationality for the gynecologist in order to apply the most sensible diagnostic modality and treatment protocol, particularly applicable to that particular woman. Next, please. Thank you all. Again, sorry for the technical glitch, but always a pleasure to be in the ICOG seminars and teaching programs.
Thank you, Parikshit, for joining from Kanyakumari, and you have managed it very well.
Yeah.
Thank you.
So thank you, Dr. Parikshit. That was a very crisp and complete overview on adenomyosis. I just have one question because, as you said, LNG is always our all-time favorite for adenomyosis. What is the upper limit up till which you have used it at the size of the uterus
So I have used it
without the
even,
risk of expulsion? Because as long as the
yes,
cavity is not
that
distorted,
that
you could use it.
correct. Yes, absolutely right. So in a very large cavity, the important aspect is placing it close to the fundus. And I often
And
do this under ultrasound guidance to just make sure that I'm going well into the uterine cavity. Now, often when we place the LNG IUS in a big cavity and follow it up on ultrasound, you might find that the LNG IUS is slightly displaced. It is away from the fundus. But as long as you have clinical efficacy, it doesn't matter. If you have relieved the woman of her symptoms, of her pain and bleeding, that's all right. The LNG IUS might as well lie in the lower part of the uterus. But as long as it is giving symptomatic relief, that's perfectly okay. I usually don't venture to put it beyond 8 weeks, 10 weeks sized. I think beyond that, the chance of these mishaps becomes more. So I agree that that's one of the drawbacks that we have.
thank you. Thank you all once again.
Answer the remaining questions in the chat box before you log out.
I will do that. Thank you, ma'am. Thank you.
Yes, Yoga. Please invite Tarini here. Tarini, please introduce. Tarini, are you with us?
Dr. Lakshmi, there was a question I've answered in the chat box.
Yeah. Yes, Pragya, you have answered. Thank you. Tarini, are you with us?
Tarini, madam. Yes.
No,
Lakshmi,
Suyoga, you can introduce. Don't waste time in that.
please.
Okay, sir. Okay, sir. I now request Dr. Damodar Rao, sir, to deliver his talk. He's to introduce him in short, he's a consultant in OBGY, laparoscopic surgeon at Rao Hospital. He has done diploma in gynec laparoscopy from University of Louisville. He has done fellowship in laparoscopy at Beams, trained at Galaxy Care Pune under Dr. Shailesh Mulkambekar, sir. He has done a postdoctoral fellowship in endogynec course in 2012 and reproductive medicine in 2016, affiliated to Tamil Nadu, Dr. MGR Medical College and University. He has been the Joint Secretary of IAGA Tamil Nadu. He has been the organizing secretary of UA Foxy South Zone in 2019 and treasurer at Koval OBGY Society. He has awards and achievements to his credit, and he has received the Best Paper Award at IAGA 2010 in laparoscopic suturing techniques of the myoma bed, and Best Paper Award in hysteroscopy in infertility in 2012. So I request sir to please
Yeah,
proceed.
thank you so
And
much for that kind introduction. My topic for today is on fibroids. Are you able to see my screen?
Yes, yes.
At the outset, I would like to thank Lakshmi ma'am and Parag sir and ICOG for this opportunity. Um, yeah, okay. I think it's on full screen now. You're all able to see it.
Yes, yes.
yes,
I'll
sir.
try and
Yes, sir.
finish everything about fibroids in 15 minutes. So, these are, of course, as we know, they are benign monoclonal tumors of smooth muscle cells of the myometrium, and they're also known as myoma, leiomyoma, or fibromyoma. They're the most common tumors of the uterus and pelvis, and is also the most common reason for hysterectomy. Right? Risk factors are, of course, age, endogenous hormones, a family. There's a genetic angle to it also, and Afro Americans are more vulnerable to it. And of course, the decrease by green vegetables, exercise, and interestingly, smoking. Pathogenesis, again, they speak about a myometal stem cell, and then you have to have these genetic aberrations of MED12 and HMGA2, which cause the fibroid stem cell under the influence of gonadal steroids like estrogen and progesterone and the growth factors, and they cause proliferation of the fibroid stem cells, and they form the uterine fibroid or the leiomyoma as we know it. Coming into the classification, there are three types of classification, right? You have the FIGO, you have the Wanstaker, and the STEP W. All three are used in different contexts. Figo is usually used like when you want to talk about it to your colleague or to the patient. I'll just run through it. So the Figo, there are type 0 to type 8 based on the location, starting from completely intracavitary to the completely subserous fibroid. You have type 0 to type 8. And of course, the step W classification is the kind of classification which helps you to operate. It tells you the complexity of the surgery. So it takes into various factors like the size, topography, extension of the base, penetration, and the lateral wall extension. And there is a score given. 0 to 4 is low complexity. You can do a hysteroscopic myomectomy for this. 5 to 6, it is a complex case, and then you might consider a two-step hysteroscopic myomectomy. And if it is 7 to 9, ideally you go for a laparoscopic myomectomy, or even if it an open myomectomy based on your experience, right? Then you also have the One-Stecker's classification, where you talk about type 0, totally intracavitary, type 1, more than 50% in the cavity, and type 2 is less than 50% in the cavity. Clinical features, we all know it causes heavy menstrual bleeding, bulk related problems, and of course, reproductive outcomes like infertility, and it can also cause complications in pregnancy. Now, diagnosis. I think, like Parikshit sir said, like we all have a TVS in our offices, and a 3D TVS gives you a pretty good accuracy for diagnosis of fibroids, but still the best in terms of multiple fibroids. If you want to do a fibroid mapping and things like that, an MRI is the best. Coming to management, of course, like anything, we have the medical management, we have the surgical management, and we also have other methodologies. Medical management, we have the traditional NSAIDs and antifibrinolytics, which are tried, and you have the OCPs and progestins, and newer drugs like the LNG, the SPRMs, which were tried, and of course, GnRH agonists and antagonists, which are here to stay. Let me just take you through the medical management. Expectant management, I think you have to ask these women if they're of significant size, say of about 2-3 centimeters, you have to ask them to be on a follow-up and see if they're growing more than the rate of 1 centimeter per year. And I think you should operate on these patients no matter what, if they cross about 7-8 centimeters, I think, because, and depending on her age, if she's close to menopause, of course, leave her alone. But if she's in her 38, 40, and it is of significant size, I think you should advise them for surgery instead of saying, no, you don't have symptoms. Because I've seen many patients that come up at the age of, 44, 45 with 15 centimeters fibroid, and they only want a myomectomy and no hysterectomy. So if these people were guided better, or, intervention was done earlier, they could have saved, a morbid surgery or a difficult surgery. So coming to medical management, of course, the NSAIDs, and you have the tranexamic acid, uh, and then you have the contraceptive pills. Again, contraceptive pills only give you symptomatic relief. They're not going to cause a decrease in the size of the fibroids. This you should keep in mind, right? LNGIUS is very nice, very useful. Again, it has, it should be fibroids of ideally less than 3 centimeters in size, and definitely not cavity distorting. So probably you can give them a GnRH agonist for 3 months and then see if they come into this category, and then definitely you can use a LNGIUS. It's very, very useful. Agonists, GnRH agonist, again, is very useful, but again, these are all temporary, right? Short-term preoperative use to reduce the fibroid size and to correct anemia, to bridge the gap between menopause in perimenopausal women, and temporary symptom control in AUB, or before an IVF if you want to bring down the size, and or before a hysteroscopic surgery if you want to bring down the size, you can also use GnRH agonists. Usually, we do not prefer it in laparoscopic surgeries, because before laparoscopic surgery, because it causes the planes are lost. So generally, we don't prefer it for a laparoscopic myomectomy, but hysteroscopic myomectomy, of course, they're given. And if you're going to give it for a longer time, you give it with add-back therapy. GnRH antagonists are also the new kid on the block, and they again are useful for fibroids. What is used now is your elagolix in a dose of 300 milligram twice a day. You can use it for a maximum of 24 months. And the side effects are very similar to that of your agonist, but not as much. Your headache, nausea, mood disturbances, hot flashes, night sweats, they're all there. Coming to SPRMs, these were tried, like the uripristal acetate was very, very promising, but then finally it was suspended because of liver toxicity, right? So it is completely given up now. Mifepristone, some still tried, but again, not FDA approved. Coming to agonists and antagonists, this is what is, I think, and your, of course, LNG, IUS are what are approved by your ASRM and ESHRE, but these are all only for short-term use, right? And they're, of course, not fertility enhancing. They're only going to give them symptomatic relief, and it's only for short-term use, the medical management. When it comes to a proper, treatment, it is definitely surgical management, either for symptomatic relief or before, for a fertility enhancing surgery, right? You have your traditional abdominal, or you have your hysterectomies also. You have your abdominal myomectomies, or you have your hysteroscopic myomectomy, and you have your laparoscopic myomectomy, and now you also have your robotic myomectomy and hysterectomies, of course. Choice of procedure completely depends on, I think, the location of the fibroid and her symptoms, right? The location and size will play a huge role. When it comes to, I'll come back to the slide in a bit, sorry. So I was talking about the route of myomectomy, whether it's hysteroscopic or laparoscopic. So there are certain criteria that are there, right? Basically, submucous myomas, type 0, 1, and 2. Uh, you can do a hysteroscopic myomectomy. Again, type 0 up to 4 to 5 centimeter, 5 to 6 centimeters also, it's fine. But if it is a type 1 or type 2, I think you should have a cutoff of 3 centimeters. Then again, based on your skill, you can think of dealing with something that's 4 centimeters. But I think 3 centimeters is a good cutoff. A very, very skilled hysteroscopic surgeon probably can do a 4 and 5 centimeters. There are people doing large fibroids by hysteroscopy, right? Type 2, again, it is better you talk to your patients about a multi-stage procedure, or you can give them a GnRH agonist for 2 to 3 months, bring down the size, bring down the vascularity, and then operate on these patients, right? Um, now, this was a particular slide I wanted to talk to you about. This is during your surgery. What we all want to do is, hemostasis and bleeding control. So this is an AHL practice guideline that came out in 2024 September, right? Just about a year back. So leuprolide acetate, your GnRH agonist, is completely indicated, especially in hysteroscopic myomectomy for 3 months. Laparoscopic, it's a little debatable. I think it depends on your preference, right? Misoprostol also can be given. Other things like your vasopressin, definitely we use it for our laparoscopic myomectomy, and tranexamic acid also can be used, right? So I'll just dive. I think I just have about 2.5 minutes left. Hysteroscopic myomectomy, of course, the fluid, all what we're all worried about is fluid deficit. If you're using saline, 1000 ml, anything about 1000 ml, anything about 2500 ml is safe. If you're using glycine, above 1000 ml is the cutoff. And of course, we're worried about things like bleeding and adhesions, and air embolism is very, very rare. This is a video using a resectoscope, and this is a type 0 fibroid. That is being done, and you have to be careful of the pressures that you use and the amount that is absorbed. So always have your team around you so that they know exactly how much of fluid is being absorbed. This is a video of vasopressin myomectomy. I'm going to skip this. I just short of time, I'm sorry. Coming to laparoscopic myomectomy, again, I think I'll just take you to a video straight. So basically, we use vasopressin, 10% solution is used. And here you can see that here we also did uterine artery occlusion because it was not a case of fertility. If it was fertility, then you can use a shoelace knot, right, which is reversible. And getting into the right plane is very, very important. And in this particular video, I've also shown use of Vicryl, which is sort of given up now mostly. This is a cavity obliterating suture that is used, and then figure of 8 sutures again using Weichel, and in the end we use your V-lock or barbed sutures, right, for a good approximation. These are all huge fibroids which can also be done. It completely depends on your skill ultimately. But in laparoscopic myomectomy, the most important thing is good multi-layer closure is what is very, very important, right? So I think I just have again coming to extraction. Extraction in endo bag is very, very important, or you do a mini lap and then you take it out. Again, non-surgical methods are there which are not used in fertility and still need more papers. So I'd like to conclude by saying that submucosal and cavity distorting intramural fibroids may be removed to improve pregnancy rates in fertile women. Fibroids unlikely to cause recurrent miscarriages. Preoperative GnRH may be given to improve surgery outcomes. Vasopressin and misoprostol effective for reducing blood loss in myomectomy. Morcellation to be done after careful patient selection and informed consent. Consider in-bag morcellation. Myomectomy is the procedure of choice in patients demanding fertility. Role of UAE and other newer management options yet to be clear. Trial of labor can be given safely in selected patients after myomectomy. Thank you.
Thank you, sir, for your enlightening talk. And any questions from the audience or any comment from the chairpersons?
Thank you, Dr. Damodar. That was an excellent overview. Of course, as you said,
Thank
15 minutes is too short to cover the entire gamut of management and other options. Anyway, you've done justice in whatever short time that you.
Thank you, ma'am. Thank you.
Excellent presentation.
We can proceed to the next session, Dr.
Yes, ma'am. Chairpersons for the next session are Dr. Mala Srivastava, madam. She is senior consultant and professor at GLIPMER, gynec endoscopic and robotic surgeon at Shri Gangaram Hospital, New Delhi. She has special areas of interest in gynec and oncology, gynec endoscopic surgery, and gynec robotic surgery. She has done her special training in fellow of minimal access surgery as well as trained in robotic surgery at France. She is a member of many organizations as well as she has held many posts in Foxy as well as at Narchi also. And I would like to welcome Dr. Mala Srivastava, madam, to this webinar, to this workshop. Our next chairperson.
Dr. Yoga, a minute. And Dr. Yoga, just a minute before this, and congratulations to Dr. Damodar. I just wanted one question. Anyway, I'll ask in the box. Okay, thank you so much, Dr. Yoga. Thank you so much.
Thank you, madam. Thank you. Thank you. Okay, so we move on. I welcome Dr. Sunita Wadhwani, madam. She is the president of Ratlam OBGY Society, director and consultant at Ratlam Hospital and Research Center. She is an NABH assessor. She has done MBA in hospital and healthcare. Her special area of interest is critical care obstetrics, and she is lead assessor and master trainer in Manyata by Foxy. I welcome madam to this workshop. Next chairperson is Dr. Ramakrishna Purohit, sir. Okay, so I would like to request Dr. Mala Srivastava, madam, to introduce our speakers for the session.
Dr. Achla will take the third talk, so we can go on with the second one.
Yeah.
Okay. Madam is there.
Everyone, it's my pleasure and privilege to introduce our star speaker, none other than Dr. Ashwath Kumar. He is a professor, Department of Gynecology, Jubilee Mission Medical College, Thrissur, Kerala, ICOG Governing Council member, IAG Managing Committee member, Foxy Quiz Committee Chairperson, President KFOG, Vice President Foxy, Vice President KFOG, and past Secretary General KFOG, with lots and lots of awards to his credit, which include Dr. D.C. Datta Prize for Best Publication, C.S. Dawn Prize for Best Presentation, Shivali Rudra Sinha Prize Best Paper for Endoscopy, and Pride of Foxy Award and Foxy Sun Traveling Fellowship. He has authored many, many books, and he has organized quite a few programs for the PG training. Today, Dr. Ashwath is going to speak about AUBC coagulopathy, when to suspect von Willebrand disease, and the approach. Over to you, sir, for your scientific delivery.
Okay, madam. Just 1 second. Madam, can you see my slides?
Yes.
Yes, sir.
Yes, we
Yes,
can
sir.
see your
Can you hear
slide.
me? Okay.
Yes, we can hear you.
Thank you, Lakshmi madam, and the whole ICOG team for inviting me for this prestigious event of ICOG courses. So today you are listening to almost you covered the palm. Now we will be going to coin part. So in the coin, the first is coagulopathy. All these things have already been told, the evolution and all these things. We will go directly to the topic. So the coagulopathy, what AUBC coagulopathy consists of? AUBC coagulopathy consists of coagulation factor deficiencies, especially von Willebrand's disease, hemophilia, platelet function disorders, and a prevalence reported is 13%. So we never believed that such a large prevalence of AUBC is there, especially with von Willebrand's disease. Previously, what changed in the new classification for the postgraduates or the students is that, see, previously pharmacological agents were added in this. Now we have removed pharmacological agents and we have included it into iatrogenic. So drugs which were causing clopidogrel, like drugs which were taken, were included, and that has been changed. Okay. So what does it include? It includes all the systemic disease of hemostasis. Most of this AUBC diseases, this all hemostasis, 24% of them present with heavy menstrual bleeding. That is our importance. And the commonest disease that is asked is a von Willebrand's disease. That is why Lakshmi madam has specifically told me to give more importance to von Willebrand's disease. Estrogen, as it promotes von Willebrand synthesis. Other causes include platelet dysfunction, coagulatory factor deficiencies. Hypothyroidism may manifest as mild form of von Willebrand's disease. Okay. AUBC can be classified as hereditary or acquired. It should be which woman coagulated problem should be considered. That is a question usually we ask. Whenever there is a patient, woman presents with heavy prolonged menses from an early reproductive age, history of frequent bruising, epistasis, gum or dental bleeding, postpartum hemorrhage, severe surgical bleeding, or family history of all these issues are there, then we suspect coagulopathy as a cause for AUB. So the bleeding disorders can be classified as hereditary disorders and acquired disorders. Hereditary disorders, the most common being the von Willebrand's disease, all ABC types of hemophilia, any factor deficits, classically 5, 10, 7, 13, prothrombin deficiency, ephraimia, and acquired like DIC. You can have acquired leukemia, aplastic anemia, renal or liver disease, sepsis, or DIC. So in short, okay, how does it present? Like most of them presents with puberty menorrhagia or heavy menstrual bleeding, or they can have suggestive of many things, suggestive of bleeding diathesis, or a family history may be there. On examination, she may have pallor and easy bruisability, and petechial hemorrhages will be there. You have to examine from head to toe. Most of the time, uterus normal size. A scan will be also normal. Sometimes in these patients, there may be ovarian cyst, which is a hemorrhagic cyst. That is, it is due to bleeding. Many times we see hemorrhagic cyst, the same thing. Like patients taking warfarin, patient may come with bleeding. Like that, you may see. Like that, due to bleeding disorders, in these patients also you have. So, you have suspected. When you suspected, you take the history properly. obtain a history and conduct a physical examination. You have to take history of concomitant any medications and shift it to AUBI. It is not considered, so it is ruled out. So we come to AUBC, heavy menstrual bleeding, either puberty, menorrhagia, or bleeding. Indications for screening. See, you cannot screen for all the patients. So what are the indications for screening of coagulation disorders? One of the following: either the patient is presenting with PPH, surgery-related bleeding, or a bleeding associated with dental work. At least two of the following symptoms. That is, at least one episode of bruising per month, at least one episode of epistaxis per month, frequent gum bleeding, or a family history of bleeding disorder. So in the first category, at least one should be there. In the second category, at least two symptoms should be there. That is when you screen the patient for examination. As I told you, it's from head to toe. So fundus, conjunctiva, neck, mouth, abdomen. You can have hands, joints, feet, urine analysis, everything, observation, see, general well-being where there is a pallor. So it is a complete assessment. It's taken from the medicine Hutchison, the picture. It's a complete assessment of a bleeding disorder actually. So you can wait pallor, breast acne, hirsutism, because many times all these things like Cushing's, all the related disorders, we will show you which are the related disorders which you have to be ruled out. So don't think that coagulation means a factor deficiency. It can be a part of many diseases. So check the general features of coagulation bleeding disorders. Everybody here should know two things. See, a bleeding disorder can be of two types. Okay. Either it can be a clotting factor deficiency or it can be a platelet deficiency. Okay, you understand? Clotting factor deficiency, it's a very important slide. Platelet deficiency. So whenever a patient you see all the platelet deficiencies, you see the subcutaneous bleed. Okay, oral cavity, nasal, subcutaneous, sorry. Okay, subcutaneous bleed. Why? Like diseases like hemophilia, you remember patient coming with hemarthrosis, joint muscle hematomas, excessive bleeding from minor cut, actually platelet, small cuts, excessive bleeding is seen with the platelet disorder. All this major clotting factor deficiency, you don't see usually bleeding from cuts actually. Petechiae are more common with platelet disorder or superficial, I told you. Ecchymosis very small, but ecchymosis large subcutaneous soft tissue hematomas can be there with factor deficiencies. Hemarthrosis, muscle and all I told you with the factor deficiency. Bleeding with invasive procedures including surgery. So only point we have to remember is that, see, platelet defects, immediate bleeding. Clotting factor defects may be associated with procedure bleeding or a delayed bleeding. So whenever you have a immediate bleeding, when you have a cut, it will be most of the time a platelet disorder. So you understood. Here the fallacy here is that von Willebrand's it's a factor deficiency, but it has bleeding problem also. So it has platelet problem also. So it's a combined thing. So that is the importance of von Willebrand's. We'll show you all the things. So this is what the different diseases which you have to know: scurvy, amidosis, liver disease, so all this can be hypothyroidism, Cushing syndrome. So it is evaluation of a patient for clotting disorder is not an easy thing. Just to say check the PTA, PTT, you will get it. It is not like that. You have to be very careful, very meticulous, and you cannot do all the tests for every patient. That is the take-home message. So what investigations you will do? You will do a complete blood count, urine pregnancy testing. One thing everybody should be take home is that every patient of bleeding, you have to do a urine pregnancy test. And because in a reproductive age group, the bleeding, the first thing what in many of your other speakers would have told the same thing, and the beginner it would have been a dictum to do a pregnancy test in a reproductive age group because it may be an abortion. Patient may come with different, but you have to be careful. Then you do bleeding time, platelet count, prothrombin and APTT. You can do for all adolescents. That is a must. But positive screening for coagulopathies like testing for von Willebrand's disease, ristostatin, cofactor activity, factor VIII activity, and recommended only when you suspect. So I will tell you, TSH and prolactin can be done for all. So what things can be done? You can do a complete blood count. You can do a platelet count, APTT, PT. You can do for all patients who comes with bleeding. You can do a pregnancy test. You can do a TSH and prolactin. Other tests you have to be thorough. So for a clotting coagulation disorder, history is one of the most important. As I told you, you should have that history criteria. The first criteria you should have 1, and the second criteria you should have 2 to say that from the history that I will be doing for coagulation. Followed by confirmatory test. What? Once you know that you have suspect a coagulation disorder, you want to know what it is. Then you do the rest of the things along with. Then you do the von Willebrand's antigen, restorative cofactor, collagen binding, and factor. We will come to it after. You can do an LFT also. See, this picture is very important. You should understand it. See, prolonged prothrombin time, you can get in factor 7 and early anticoagulant therapy. What you get is a prolonged prothrombin time. APTT can be prolonged in all factor deficiencies and von Willebrand's disease. You remember, prolonged PT and APTT also, deficiency of all these things, and von Willebrand's disease you can have. The most important is that, see, usually bleeding time has taken out of our we don't do nowadays bleeding time. But one of the most important thing is that bleeding time shows the platelet function. So in von Willebrand's is the only disease, only factor deficiency where you will get prolonged PT-APTT as well as bleeding time. So all of you, I think, understood one important point. Bleeding time is an additional thing. When you get it is factor deficiency. You can go in very simple nowadays doing bleeding time. So general treatment, we will come to von Willebrand's in 1 minute. General treatment is that non-hormonal treatment, tranexamic acid, hormones like COCs, LNG-IUS is as a second option. Uncontrolled uterine bleeding, specific factor replacement, or a desmopressin in refractory case, we will come to it after. I will tell you. Surgical interventions are indicated, appropriate pre and intraoperative management of bleeding. NSAIDs are contraindicated. They alter the platelet function. So be careful with NSAID, and that might affect the liver function and production of clotting factors. So please, whenever you suspect, don't put patient on NSAIDs. Whenever you are using a coagulation suspected, whenever you are using injectables, please see that it is administered properly and give proper pressure. Otherwise, you will get a large hematoma over where you have injected. So this is some of the things. OC pills, I'm not going into detail. So you can, those who want, they can take the picture of it. OC pills, how it contains higher dose, actually 35 they have written. IV Primarin, medroxyprogesterone, tranexamic acid. Even to that extent, some people have even told even you can do a intrauterine tamponade. No other way to do. You can put a Folis inside and dilate it inside the 30 ml of saline can be used. Inherited coagulopathies can be treated by factor replacement, desmopressin acetate, and hormone medical treatment. See, now I will run through von Willebrand's disease. See, there's so much to learn, but in this we have to restrict to important points. I will go through the slides, and excuse me, I will be running through the slides, but I will highlight the important points. Most common inherited disorder can be congenital or acquired. Von Willebrand's disease results from deficiency, not only deficiency or abnormal function of von Willebrand's factor. Von Willebrand factor is a multimeric glycoprotein. So encoded by gene MAP12P13, made in endothelium, stored in Weber Pallade bodies. Here is the point. Two functions are there. One is assist the platelet plug formation by attracting circulatory platelets to site of damage. That is one. So platelet has come and it binds with coagulation factor 8, preventing the clearance of the plasma. So you understood that von Willebrand's factor, you know that it's on both sides. So the same thing has been written in detail. Platelet and the subepithelium to promote platelet adhesion, activated platelet to promote platelet aggression, and factor 8 to prevent premature degradation of coagulation factors. Sorry that these are all pictures. See, as a lack of time, I cannot explain this. So you can see A3 gets binds, exposes A1. To that, you can see platelets get attached. So activation is that change the shape, flip-flop, that is a procoagulant phospholipid that brought to the surface of the inner part of the bilayer. So you can see here. And third part is that GP2B3A is organized. Okay, granules release von Willebrand's factor and fibrin to surface. This is the basic activation of von Willebrand's disease. Expose and outpour. So Coming to the matter, I will tell you, there are 3 hereditary types of von Willebrand disease. 1, 2, 3. There is something important to know this, I will tell you. Acquired also called pseudo von Willebrand disease or platelet type. Okay. Von Willebrand disease, 1 is there, 1 where, see, 1 and 3 are quantitative deficiency. Quantity is decreased. 1 is a partial quantitative deficiency and 3 is complete absence of von Willebrand factor. At least you understood. 2 is again given to 2A, M and A, B, M and N. Basically, don't confuse. I can send you the slides. It is basically functional. So it is a qualitative. So you understood both things, qualitative and quantitative. Qualitative, or please, quantitative is type 1 is a mild partial absence and type 3 is complete absence. At least you remember 2 means 2A, B, M and N are there. They are all functional. That means a qualitative deficiency. This much all of you understood, I hope. Okay. So this is the details of 1. It's a quantitative decrease in von Willebrand factor with preserved ratio between the von Willebrand antigen activity and factor 8. Normal multiple distribution. So there is something called 1C where there is ratio changes. So the increased clearance of von Willebrand occur. So 1C is there. 3 is complete absence. So at least you learn 1 is partial and 3 is complete absence. And 2, A, B, M and N, look, lack of time not explaining, but it's all simple things. All are functional. That is the qualitative deficiencies. So quantitative, qualitative. Okay, this is same thing what is written. This is the details how it functions. Okay. Everybody listen to one thing. Von Willebrand's 60 to 80% are type 1 von Willebrand's disease. So most of the time it goes undetected. Okay, undetected. Only in severe case we come into, so it gets undetected. But in Indian studies, you see, all the Indian studies have taken, all the Indian studies, you will see type 3 is maximum, not type 1. Why? Because in India, only the severe cases come to, we don't have any screening method. So we don't do routine screening. So what happens is that only type 3 come to the hospital. We have only data of type 3. So we documented that type 3 is the most common in India. It is not like that. It is the type 1 only is the most common. But most of the type 1 doesn't manifest that much. Patient may have an increased bleeding. Many times when you're doing AUB, you are missing von Willebrand's disease because you will be treating and the patient will be continuous. It will not be responding. She will go from one hospital to another. You will be using, each doctor will be using different things. Unless you have not tested for it, you will not detect it. Okay. So these are the
Sorry to
screening tests.
interrupt you, sir.
Sir,
Yes.
Sir,
Sir,
your point of view.
Hello.
sir, time is almost.
Time is over. Okay, I will finish it. And nothing I am doing. I will finish with the last slide because it is not. It's just last slide. I will tell 2 words and finish it. Okay. Okay.
Okay.
So the just to screening and treatment I will tell. Nothing else I will tell. I will run through it. I know that it was a big that is I took about days to prepare this because I was not understanding what it is. Then I had to prepare. That is why. Okay, sorry. So the von Willebrand's workup, only workup and treatment, nothing else I will tell. Von Willebrand's workup, screening test, platelet count, bleeding time, platelet function assay, and APTT is there. Specific tests you can do for the quantitatively, you can assess the von Willebrand's antigen. Functional assay, restorative cofactor, and collagen binding test. At least you remember 4 tests. So 2 tests, functional, quantitative test, you test for von Willebrand factor, and functional assay, 2 functional assay you learn. Ristocetin cofactor assay. One word shall I tell? Ristocetin was an antibiotic which was used previously. Why it was removed was that it causes platelet aggregation and thrombocytopenia. That principle we use here. We are not using ristocetin as antibiotic. So anybody ask you why it is used? And it is to, then you have discriminatory test to discriminate between all the type 2, A, B, M and N. So bleeding time importance, we told PFA, all this utility. One last word. This is the chart tool which is it. So first bleeding time is an important. Next is ISTH bleeding assessment tool. This is just a, you will get in the net. You can download it, you tick, and this is the most important thing. And it is the, if it is the score, ISTH BAT cutoff score. Please, all of you remember, this has to be remembered if you have gone polyvalent. So if the adult female, the score is more than 6, that is the person who have to be investigated further. And the last slide, this is assay we told, assay, activity, all these things are there. Collagen binding assay, leave. Treatment, last 2 slides. The treatment of von Willebrand's disease, see, the best is, the easiest is cryoprecipitate. Cryoprecipitate, so cryoprecipitate contains 1 fibrinogen, 8 and von Willebrand's factor. So if you are suspecting, because all the other drugs are very costly, cryoprecipitate, 2 is desmopressin and 3 is tranexamic acid. Simple. Okay, tranexamic acid has to be given. So desmopressin available as nasal sprays. Okay, nasal sprays, and you can get factor 8 and that's very costly. Von Willebrand's factor concentrates are there. This is the last slide of the day. There are different types of von Willebrand's disease. Take home is von Willebrand's. One is only respond to desmopressin. It's partial. Von Willebrand's 3, no chance. So other you can use cryoprecipitate. So if it is von Willebrand, so just desmopressin is not the treatment of choice. It is treatment of choice for type 1 only. Type 3, when there is no factor, it cannot act. So no use of desmopressin. All the other conditions, at least you learn cryoprecipitate can be given. So this is what is a. So thank you so much. I know that it was, and I wanted to share a experience of cases, but that would have been very interesting. But it will take another 1 minute. Sorry. So if you give me, I will tell you one incident which you will never forget. That is why if you give me 1 minute, I will finish. If it is there. Eh?
We are behind by 20
Okay, no problem. Because it was 2 cases which I managed there, and then you will understand what it is, whole thing. No problem.
in the chat box if possible.
Let me see. Thank you. Sorry, madam, for taking on it. Just so much. Once you start reading von Willebrand's disease, it is. So I wanted to share maximum to the people who are, because everything, all the other things in our textbooks. This is not in our
Dr.
textbooks.
Panna.
Thank you.
Thank you, Dr. Ashwat. It's always a pleasure to listen. Sorry we had to cut you.
Thank you. No problem, madam. Another talk we will.
Thank you, sir. Now I would request Dr. Sudita Wadhwani madam to introduce Dr. Achila Batra madam for her next talk.
Very good evening to Dr. everyone. At the onset, I would like to thank Dr. Lakshmi Shrikhande madam for giving me this opportunity of being a chair on this session. And I would extend my regards to Dr. Parag Baniwala and team ICOG who have got such a beautiful workshop to our doorsteps. I mean, it is such a big pleasure to hear to all beautiful speakers around here. It is my privilege to introduce the second speaker of today's second session, Dr. Achila Batra. Ma'am is a National President, NARCHI 2022-2024, Governor Council member of ICOG in 24-25, Chairperson of IHCP Division Stillbirth Society of India, member of FOXY Project on Reducing Caesarean Birth, President NARCHI Delhi 1920.
Thank you, Sunita. Thank you very much.
You have so much to be read about, ma'am. I'll just complete the list. Professor Obsgani, VMMC, Safdarjung Hospital, Review International and National Journal, contributor to various guidelines and various publications to her credit. Welcome, Dr. Achila Batra, ma'am.
Thank you so much.
She would be talking about AUPM, that is malignancy.
Yeah. So thank you, Dr. Lakshmi. Thank you, Dr. Parag, and my worthy chairpersons who have, who are chairing my session. So I am going to share my slides now about AUPM. Can you see my slides?
No, ma'am. No, ma'am.
Okay, I will.
You need to share it again.
Okay. Okay, I'll do that again.
Yes, ma'am, we can see it now.
Now we can
you
see your
see it
slides,
now?
Dr. Achal. Yeah.
Yeah, but it is not in the full screen
Thank
mode.
you. Yeah,
We
I'll
need
do that.
to do it in, yeah.
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 Thank you, Dr. Mala, Dr. Sunita, and Dr. Purohit for being my chairpersons. And thank you, Dr. Lakshmi, for inviting us. Excuse me. AUBM stands for abnormal uterine bleeding due to malignancy and hyperplasia, as we've been talking about, all classified by FIGO. And it includes bleeding caused by endometrial carcinoma, hyperplasia, or other uterine malignancy. How the patient present may be postmenopausal bleeding, heavy menstrual bleeding, intermenstrual bleeding, prolonged or frequent. Why we have to do risk stratification for AUBM? In postmenopausal women, we know that we suspect endometrial cancer. But in premenopausal women, endometrial cancer is overlooked because of its low incidence. And we cannot be doing DNC for everyone. So if we do risk stratification, we can prioritize the patients who have high possibility of disease, and we don't use all the increased tests blanketing. So what are the risk factors? Clinical risk factors. We have imaging based stratification. Then we have risk of endometrial cancer. And there are various validated prediction model which integrate clinical, imaging, molecular data to identify individual at elevated risk. But it has been seen that basically the clinical risk factors and the imaging-based certification is most important. Now, in clinical, we have obesity. In obesity, there is increase in the circulating estrogen levels. So body mass index more than 30 kg per meter square is a significant risk factor. Chronic anovulation, irregular period as in PCOS, age especially more than 45 years, diabetes, nulliparity, HRT if unopposed estrogen. So basically hyperplasia is because of unopposed estrogen, and if you give HRT with only estrogen, that is another risk factor. Tamoxifen use, we all know it increases endometrial hyperplasia. Family history of Lynch syndrome, very high risk of hyperplasia and endometrial carcinoma. There has been developed a PAD-3 risk scoring system, though not been validated much, but I found it really good because with one factor, you won't make a person high risk. So they have taken age more than 41 point, anovulatory penetrance 3 point, presence of diabetes 3 points, BMI more than 30 kg per meter square 2 points. And a total PAD 30 score of more than 5 is suggestive cutoff for identifying high-risk women. Sensitivity 85%, specificity 87.6%, and if they have a likelihood ratio of 6.91 in 50 of endometrial hyperplasia atypical of carcinoma becomes 30% before pretest. So it is avoid unnecessary endometrial biopsies. Imaging, very, very important. Endometrial thickness, more than 4 to 5 millimeter in postmenopausal women, more than 14 millimeter symptomatic premenopausal women, those who have prolonged irregular bleeding, may raise concern for hyperplasia or carcinoma, especially if their risk factors are there. And more than 15 is definitely abnormal, regardless of the cycle phase. We all know we have been hearing about the cycle and the endometrial thickness in various phases, but 14 and 15 cutoff is important. Then, if you see on ultrasound, interrupted endomyometrial junction and heterogeneous ecotexture, that is suspicious, and vascularity increases very much in malignancy. The risk of malignancy score integrates the ultrasound finding as well as the clinical findings. So they gave a score, endometrial thickness, less than 50, 6 to 11, 1, and more than 12, 3, interrupting junction 2 score, power Doppler, if it is abundant 3 and moderate 1:2. And if additional modifiers like irregular contour, mass, fluid, clinical risk factor, they are given a score of 1 each. So if their total score is more than 9 patient is at high risk. So if you have a premenopausal patient who is less than 14 years, you do with AUP, you do a TVS, and you find the RAC score more than 9. She is high suspicion, and then you must proceed for biopsy or hysteroscopy as applicable by ultrasound. So how we make a diagnosis of AUPM? Of course, by histopathology. Positive finding means hyperplasia. Now, the previous classification of, complex hyperplasia,
cystic gland, all are gone. Now we only say very simply hyperplasia without atypia, hyperplasia with atypia, or endometrial carcinoma. So we can do endometrial sampling. We had a long lecture on the sampling methods. We know it is a very convenient, has a good sensitivity for perimenopausal women as well as postmenopausal women. And for atypical hyperplasia, it is 81% sensitivity. You don't have to do diagnostic hysteroscopy for everyone, but when the outpatient sampling fails or is not diagnostic, and when hyperplasia is diagnosed within a polyp or lesion on ultrasound, then you must go in for hysteroscopy. So how do we manage once we find hyperplasia? We know hyperplasia is the precursor of endometrial carcinoma, but if it is without atypia, the cumulative 20-year progression risk to endometrial cancer is less than 5%, and most cases will regress spontaneously. Initial step is identify and correct the reversible risk factors like obesity. If she's diabetic, control her diabetes. Other things cannot be controlled. And the first line treatment for hyperplasia without atypia is LNG-IUS. It offers local concentration of progesterone and better regression rates, fewer systemic side effects, and lower likelihood of requiring hysterectomy after. It is also a contraceptive method. Minimum treatment duration is 6 months, but if you retain it 5 years, it is preferable, and fertility is not desired in this patient because it reduces the relapse risk. Alternative method, patient who doesn't want to take the LNG, you can give oral continuous progesterone, you can give medroxyprogesterone 10 to 20 milligram, or norethistron 10 to 15 milligram per tray, or magistrol 160 to 320 milligram per day. It has to be given continuously for 6 months. And if still the hyperplasia persists, then you have to shift to LNG. But you should not give cyclical progesterone, and you should not be doing endometrial ablation, combined pill, or TNF agonist in these patients. Surveillance, how these patients, once you have treated them conservatively, you have to do every 6 months the aspiration to see what is the status of hyperplasia, and they have to be 2 consecutive negative endometrial biopsies, then you can leave them alone. But we have done a risk scoring when we have seen a patient at AUVM, and if the patient is high risk, she has a high BMI, or she is being treated with oral progesterone and not with LNG, then you have to do annual endometrial sampling even after 2 negative biopsies till the woman is well into menopause. Hysterectomy is not offered as a first-line treatment due to high regression rate of the progesterones. It is indicated when after 12 you don't have any regression, or it progresses to atypical, or if there's a relapse, or the bleeding is not controlled, or if you think the patient will not comply with treatment and surveillance. For postmenopausal, you can do hysterectomy with bilateral salpingoidectomy. Premenopausal, you can do hysterectomy with salpingectomy, and BSO, as usual, the decision is individualized. What if you have atypical? High risk of malignancy, 30%, and other cancers can also be there, like ovarian. First line treatment is total hysterectomy because of the high risk. In postmenopausal, of course, with BSO, in premenopausal, you can do salpingectomy, salpingoidectomy. If everything is all, you may just do salpingectomy, depending upon the patient's wish and your high risk factors. But you don't have to do any frozen section analysis or lymphadenectomy in these patients. Suppose the patient has atypical hyperplasia and she wants to conceive. So you have to tell her about her risk of cancer, tell her about lifestyle modification, which reduce the recurrence risk like weight loss, glycemic control if she is diabetic. We must do pre-treatment transvaginal ultrasound CA-125, if MRI, if you think there is a doubt, and hysteroscopy with targeted biopsy or DNC must be done to rule out carcinoma. And the surveillance is very important. That will be same as we do in typical, but in cases which they have a small polyp, or if you think there's a small growth, you can do a targeted biopsy every 3 months, unless 2 biopsies are negative. After 2 negative also, patient has to be on long-term follow-up, maybe 6 months, maybe 12 months. And it should be done for 2 years only. In that period, she should be able to conceive. And or if she conceives earlier, or she thinks she doesn't want fertility, then you do hysterectomy. The ultimate treatment is hysterectomy. And the fertility following treatment, it is better to offer them ART because it has been seen that there's higher live birth rate, and it also so that they finish their course earlier. Pregnancy rates have been found to be 26.3 to 41% who opt for progestational agents, but you should only try for fertility once the tumor has, the hyperplasia has regressed. Only then you will give her fertility treatment. And of course, after fertility is no longer desired, hysterectomy has to be done, like I said. And if there's no regression after 12 months of therapy, persistent or recurrent atypical hyperplasia, or it progresses to carcinoma, or if you think patient is non-compliant, it's better to abandon the fertility sparing treatment and go ahead with the hysterectomy. Malignancy, I'm not talking about because that is a special feed in malignancy. The treatment has to be as for endometrial carcinoma, and then you'll have to do the biomarkers. So basic key takeaways are that risk stratification is very essential. Just don't treat the patient, must do risk stratification, must take into account the epidemiological factors like diabetes, bleeding patterns, BMI. Ultrasound transvaginal is very, very important because it offers valuable insights into endometrial characters and guides further management. And of course, the histopathology confirms the diagnosis. And if you have a case without atypia, then the levonorgestrel device is the preferred treatment for, supported by close surveillance. In atypical, total hysterectomy is the first line. And fertility sparing, like I said, progesterone can be given, but only for 2 years, and hysterectomy planned after childbearing is complete.
Thank you very much, Dr. Achala ma'am, for being so precise and crisp in your presentation. It was indeed a very informative and a nice presentation. Thank you very much.
Okay, so we now move on to the third talk. Ramkrishna Purohit sir is here. Okay. Sunita madam, can you introduce
I
Dr.
can
Kshama
take
Kedar,
the
ma'am?
opportunity of introducing Dr. Shama Kedar.
Yes, ma'am.
Yeah. It's my pleasure to introduce our third speaker of the evening, none other than Dr. Shama Kedar. Dr. Shama is Associate Professor and Unit Head, Obstetrics and Gynecology, Indira Gandhi Government Medical College, Nagpur. She is the President of NARCHI, Nagpur Chapter, Secretary Knox, Vice President, Menopause Society of Nagpur, and she is the Treasurer of AMWN Nagpur, Associate Member of RCOG. She had been faculty in different societies and different programs with great achievements. She has developed unique workshop of pelvic anatomy revisited and evidence-based cesarean section. She has authored quite a few books and written many chapters, and we are waiting to hear from you, Dr. Kedar, regarding AUBO, ovulatory dysfunction, PCOS, thyroid, HPO, axis disruption. Over to you, Dr. Kedar, for your scientific deliberation.
Thank you, ma'am. Thank you for letting me having me on this such a prestigious session of ICOG. I'm very much happy to be here, and thank you very much. At the outset, I would like to thank Dr. Lakshmi for having me here. Now, when we say abnormal uterine bleeding, already whenever we say the abnormal uterine bleeding, and we are talking since yesterday on this, main part has come where you have to rule out whether it is ovulatory dysfunction or not. So whenever we say about the abnormal uterine bleeding, we always say that it is a normal menstrual cycle. We should be knowing about the frequency, volume, or duration. And if there is a variation, any of this, they will be causing the AUB. So, and as it impacts in our quality of life, it's very important to rule out what is the perfect diagnosis of this condition. Now, I'm going to talk on ovulatory dysfunction. Already your coagulopathy and everyone I have heard, they have covered up so nicely. So now my turn is to cover ovulatory dysfunction. Now, as you all know, it is a AUB with ovulatory dysfunction is a type of a non-cyclic uterine bleeding characterized by irregular, prolonged, and often heavy, painless menstruation, which leads to anemia. And though it is mostly during the menarche or perimenopausal stage, but it can present at any stage of our reproductive life. And due to prolonged unopposed estrogen stimulation, there is always a risk of hyperplasia and potential cancer in the future. We just had a talk of Dr. Batra on this. Now, whenever we say regarding the epidemiology of AUB varies from country to country, and prevalence is very high from 3 to 30% internationally, while in India we have 17.9% for which accounts for 70% of our gynecological consultation. Now, whenever we say AUB in ovulation, when there is unopposed estrogen, which itself stimulates, causes endometrium to thicken excessively. And when this endometrium eventually outgrows its blood supply, leading to irregular shedding and heavy prolonged bleeding. This irregular shedding can result in unpredictable timing and amount of blood flow. This presence of high estrogen levels unopposed by progesterone is also believed to contribute to increased vascular fragility, decreased vascular tone in the endometrium, which lead in increased blood loss. So whenever we talk on mechanism, it depends on 4 parameters. That's abnormal prostaglandin synthesis and prostaglandin receptors upregulation, increased fibrinolytic activity locally, and increase in the activity of the tissue plasma. So etiology of this is due to the disturbance of HPO axis. Whenever physiological anovulation is common at the beginning of the reproductive life, when this axis is not fully mature, then it leads to puberty, menorrhagia. But near menopause, follicular recruitment may occur prematurely in the luteal out of phase and followed by precocious maturation of the follicle. This luteal out of phase results in high level of circulating estradiol and increased menstrual bleeding. So hyperandrogenism like PCOS, congenital and adrenal hyperplasia, all this lead to because of this disturbed HPO axis. Another is hyperprolactemia. Prolactemia is very common. Anorexia, excessive exercise, very much stressful condition, thyroid dysfunction, primary pituitary dysfunction, and premature ovarian failure is another etiology. While our medication, one should be properly taking care of anovulatory dysfunction, including antileptics. Whenever this patient is taking anti-epileptics, such as and also antipsychotics, one has to see that these may cause hyperprolactemia and subsequent lead to AUBO. So whenever we see all this etiology, common causes of anovulation, one should be aware that we should be taking out, ruling out each by each by doing all the evaluation. Evaluation based basically on your history, because you have detailed history specifically regarding the bleeding history. How much is the bleeding, frequency, regularity, and duration of bleeding? Specifically, one should ask how many sanitary pads she is soaking, whether they are fully soaked or half soaked, and signs of symptoms with associated with known cause of ovulatory dysfunction, and medical history, PCOS, especially whether there is acne, male type of hairs are there, or hirsutism is there, thyroid dysfunction. Specifically, one should ask for the heat and cold intolerance, hyperprolactinemia, if there is any galactoria is there or not. So contraceptive history, especially is she on cirrhosis, one should be asking. And just now we talk about the antipsychotic medicines. If she is taking, one should be taking into the consideration of such history. Family history, one should ask the mother and sister also whether they were sufferers of PCOS or any blood dyscrasia like easy bruising or bleeding tendencies in the families. One should be taking this history. Physical examination, yes, we do all this, and for annulatory bleeding is essential in identifying this potential underlying cause. Vital signs, including orthostatic blood pressure, especially if hypovolemia or anemia is suspected. General assessment of BMI and body composition one should be looking at. Head and neck, especially with the examination of conjunctiva, mucosal pallor, or thyroid abnormalities, or any swelling. Abdomen, specifically tender masses or pelvic examination, any infection, whether it is concern of STI, do pap smear, rectal examination for any bleeding because of the rectal problem, please see to this. Then whenever we say evaluate, you have to evaluate the disease properly, because whenever we do all these things, because we have to concentrate on PCOS, thyroid, hyperprolactinemia, and all these things. So whenever we say if history, one should undergo an UPT or CBC irrespective to every patient. If we are taking a history of recent pregnancy or miscarriage, serum beta HCG levels to be excluded, any trophoblastic disease. Then appropriate testing based on specific aspects of history includes PCOS, when one should be doing 17 hydroxyprogesterone total and free testosterone, FSH, LH, and pelvic ultrasound. Thyroid, one should be doing TSH, hyperprolactinemia, and if there is coagulopathy, CBC, and all these things we are routinely doing. So one should be already Dr. Ashwath Kumar has nicely said what factors should be done. Factor 8, PT, PTTK, all should be ruled out. Now, whenever age is very important, at Minaki to age 18, screen for blood dyscrasia, leukemia, ITP, hypersplenism. If this annuity cycle persists more than 2 years without an identified cause, one should be doing endometrial sampling. If age is between 19 to 39, approximately 6 to 10% will have hyperandrogenism and PCS. Again, it is not ruled out. Then after one should be doing endometrial sampling. Near perimenopause, endometrial is the first line of testing, because most of the time here the endometrial cancer or hyperplasia all sets in. Imaging, yes, imaging is the first line diagnostic to hysteroscopy, whether USG or saline infusion sonohysterography, as well as MRI is very, very important in ruling out any cause. Differential diagnosis is AUBO is the diagnosis of exclusion. DD includes all potential causes of AU system. So in spite of that, whenever you should be doing specific causes for ovulatory dysfunction should be considered to include pregnancy, whether it's there, Minaki, what is Minaki perimenopause, and premature ovarian failure is there or what, lactation, endocrinopathy, and medication use, one should be asking them in detail. So whenever we do this algorithm, always carcinoma dysfunction may be the thing. Management is first you have to stabilize the patient, because she might be acute AUV, may be bleeding, so one has to control that. But along with that, you have to discuss this problem with patient and counsel them regarding the benefits and risk of the various options, any comorbidities, suitable treatments, if she's trying to conceive, and whether she wants to retain her fertility or her uterus. Other symptoms such as pressure and pain is very important. So medical management is cornerstone for AUBO. It includes progestin-only therapy and combined hormonal contraceptive field. Progestin theme is available in several forms, including IUD, intrauterine device, and injectable, intramuscular injectable, oral progestin-only hormones. Then levonorgestrel releasing IUD is suitable for all age groups. Combine, yes, hormonal contraceptives and oral pill, transdermal or intravaginal rings are there. These options help protect the endometrium from hyperplasia and in turn prevents malignancy. So cyclic progesterone or combined hormonal contraceptive may be needed, bleeding regularity if desired. So if the patient desires fertility, we have to do all these things, and if she is ready to pregnancy, till then we have to do COCs and all these things. First correct it, and if she is a patient of PCOS, weight loss will lower the circulating androgens, and even in reduction in body weight by percent may lead to spontaneous resumptions of menstrual cycle. If pharmacological weight loss agents are also there in the market, like Orlistat or Sibutramine, one can try this. But mostly, even we always say in PCOS, lifestyle modification is the mainstay of our treatment. Ovulation in induction with letrozole or clomiphene citrate is always done. Traditionally, first line we always used to use clomiphene citrate, but recent studies suggest that letrozole is more effective than clomiphene citrate, and as they have a higher live birth rate. But if we use metformin with clomiphene, may raise compared to clomiphene alone. Now, whenever there is a surgical management, if the medical management contraindicated, then only one can do go ahead with PCOS, laparoscopic ovarian drilling, if not responding to CC, and morbid obese, one can do gastric bypass surgery to normalize the reproductive metabolic abnormalities. AUB in perimenopausal age group, endometrial biopsy or DNC is the mainstay. Now, whenever this young woman unopposed history of unopposed estrogen, endometrial sampling should be doing complete. If she has completed her childbearing age and she is near perimenopause, definitely hysterectomy. Alternative is endometrial ablation, but most of the time they say not recommended. And cases of patients developing endometrial cancer after an ablation procedure have also been reported. No, Endocrine Society
Sorry
has
to
already
interrupt you,
given a
ma'am.
GCP. Yes,
Ma'am, your time is up.
yes, ma'am. Oh, I have told 15 minutes. Sorry. So just to summarize, whenever this GCP is already given, and one has to see which are better for our patient, because prognosis is always generally favorable for this AUBO, and management of AUBO may help prevent complications like hyperplasia and malignancy. Otherwise, complications are always mostly they include infertility and irregular menses and anemia. One has to tackle with intravenous iron therapy, and the counseling and patient education and awareness regarding what constitutes the normal versus abnormal bleeding. She should be told or teach to recognize what is necessary to schedule for an appointment for a treatment. Thank you very much for your patient hearing and giving me this time to talk on such a prestigious stage. Thank you very much.
Thank you, Dr. Kedar. That was a really nice scientific deliberation from your side. You have nicely told how the ovulatory dysfunctions can lead to AUB and how we can manage and tackle it. It was an excellent talk from your side.
Thank you very much, ma'am.
So, Yoga?
Yes, madam. We now move on to the third session of this certification course. We have with us 3 chairpersons, and speakers for this session are Dr. Kiran Kurtakoti sir, Dr. Abha Singh madam, and Dr. Biswajyoti Guha madam. To begin with, I would like to introduce Dr. Abha Rani Sinha, who is the chairperson for this session. Dr. Just a minute. Dr. Abha Madam is professor of SKMC at Muzaffarpur. She is a member of the ICOG Governing Council, President Patna OBGY Society in 2017 to 18, and chairperson of Foxy Quiz Committee. She has been the vice president of ISOPAR, and she has a UG and PG testing experience also. She has contributed to many chapters in national and international journals. Next slide. We have with us Dr. Bharti Abhyankar Madam, who is a consultant at Purva Hospital, Kolhapur, Vice President AMOX 24-26, Executive Member of ISCCP 22 to 26, and Organizing Chairperson at ISCCP Con 2025. She has worked as a chairperson on the Preventive Oncology Committee of AMOX, and she has worked twice as the Zonal Coordinator AMOX. She has passed the international exam on colposcopy and cervical pathology and has conducted many colposcopy courses. She has also published a booklet on oncofocus during AMOX conference and published a book in Marathi also. She has contributed chapter and various other books. Next slide. We have with us Dr. Shyam Pyari Jaiswal. She is Professor and Head at Department of OBGY, KGMU, Lucknow, UP. And she is a member of and President of LOGS, past President ISOPAR. She has many honors and awards to her credit, Sashakta Mahila Samman, Stamba Award, Hall of Fame Appreciation, and so on. She has also has international recognition, invited as a guest and faculty speaker at the Global Congress on Women Health Gynecology in Spain, and also in the FIGO World Congress of Gynecology and Obstetrics, and many other congresses in the international region. She has been awarded with the FICM. Yeah.
Thank you so much.
Yeah, she has many publications to her credit, and I would like to request our chairperson to introduce Dr. Kiran Kurtakoti sir for his talk.
Yeah, and Dr. Bharti is not able to join. She has some emergency.
Okay.
Yeah, I
Okay.
request other two chairpersons to please carry forward the session. Yeah.
Okay, so I think it's my pleasure to introduce Dr. Kiran Kurtakoti.
Dr. Abarani, that's okay. Nobody likes politicians.
No, I'll just introduce you.
Kiran, you are too humble.
And everybody knows Dr. Kiran Kurtakoti. I know he doesn't need any introduction. He's from Pune, and at present he's Vice President of AMOGS, and he has a lot of experience at national and state and in organizing different conferences. And we all remember you as the chairperson of the MTB committee.
Thank you, madam. Thank you. Please allow me to share.
And
Yes.
At present, he's director of Shashwat Multidiscipline Hospital. And I think his introduction has gone off the screen. Perhaps he wants me to invite to talk about a very important and pertinent subject, that is AUBE. In this session, we have EIN. So he'll be starting with E, that is endometrial dysfunction. So Dr. Kiran Kurtakoti, the stage is yours. We all want to.
Thank you. At the outset, thank you, Dr. Lakshmi, because really, I mean, I would appreciate ICOG for starting this course. I hear from Nilima that there are over 1,700 people who have registered. I mean, that's really a fantastic thing. Thank you, Dr. Parag sir, for initiating this particular course. Thank you, Dr. Parag Biniwale. And of course, you have put so strong chairpersons for my talk that both of them are esteemed teachers, Jaiswal madam and Abarani Sinha, that I would request all the questions to be directed to them. मुझे questions मत पूछिए, सब questions दोनों मैडम हमारे chairpersons answer करेंगे, इतने वो माहिर है और अपने job में. So thank you so much. My job is made easy because I'll be speaking on AUBE. So whatever Dr. Ashwath has said, or whatever Dr. Kshama has said, and whatever is excluded from their talks is left to me, because after all the exclusions, it is the endometrial etiology which is important as far as the abnormal uterine bleeding is concerned. So endometrial cause is a critical subset and needs focused attention and understanding, because about 30% of the patients usually suffer from abnormal uterine bleeding as a result of endometrial causes. Now, if at all you see, this is the birth span, this is the lifespan of any woman, and if at all you see, these are the various causes of abnormal bleeding right from the birth, which is the result of estrogen withdrawal, to right at the age of 60 or postmenopausal due to atrophic vaginitis, carcinoma, and estrogen replacement. But as you can see very clearly, it is usually in the reproductive age, say between 20 and 40, that all these causes, that is the functional cause, iatrogenic cause, pregnancy, uterine, these are the causes which may be responsible for AUP. And it is our responsibility to come to a conclusion. Now, if at all we have an overview of the endometrial causes, we can understand that it is mainly because of the structural cause, or the dysfunctional cause. Now, today we are going to discuss only about the dysfunctional cause because structural causes are already covered by some other speakers. Now, most important thing is AUB that occurs in the context of structurally normal uterus. That means on ultrasound, everything is clear. On MRI, if everything is clear, there is no adnexal pathology. And in the absence of coagulopathy, which Dr. Ashwath rightly said and very innovative lecture, that in case the uterus is structurally normal, in case there is any absence of coagulopathy, in case the hormone etiology is absolutely normal, then primarily we can think of some endometrial disorder. Now, unfortunately, the diagnosis of AUBE is as a result of exclusion. So you exclude all other causes, and once you exclude all other causes, then you come to a conclusion. Now, unfortunately, tests measuring such abnormalities are not currently available anywhere. So we have to rely on only the diagnosis of exclusion. So if at all you see AUBE, when it occurs in the context of predictable and cyclic menstrual bleeding, typical of ovulatory cycles, not all ovulatory cycles, and when there is no definite cause, the mechanism is probably a primary disorder of the endometrium. Now, it may be as a result of the local hemostasis or homeostasis, as you can see. There are other different causes like deficiency in the local production of vasoconstrictors like endothelin 1 and PGF2, accelerated lysis of the endometrial clot because of excessive production of plasminogen activator, increased production of substances like promote vasodilatation like PGE2 and prostacyclin. Now, these are the other causes of endometrial etiology. But unfortunately, tests which are going to determine the levels of these products is nowhere available. So we have to rely on the exclusion of all other causes before we come to a conclusion of the endometrial cause. Okay, so this is a diagnosis of exclusion that one must remember. Now, if at all you see, this is the ovulatory cycles. There is a two phases, proliferative, secretive. In the proliferative, we all know estrogen is predominant. In the secretory, estrogen and progesterone are predominant. So here you can see irregularity in the endometrial degeneration, sloughing and degeneration, PGE2 and F2 ratio, raised PGE2 receptors, less thromboxane production, high fibrinolytic activity, decreased vasoconstrictor endothelin production. All these are responsible for abnormal uterine bleeding because of the endometrial cause. So if at all you see the pathophysiology, either hormonal imbalance, excessive proliferation, inadequate progesterone. So primarily these two, cause number 2 and cause number 3 are the main causes of abnormal uterine bleeding because of the endometrial cause. Okay. So now the clinical challenges, how do you call it abnormal? So how do you estimate the blood loss? Either it can be objective estimation of the blood loss, wherein you can do the chemical analysis, which is a very tedious procedure. This is only an academic question, extraction of heme from the used sanitary towels using 5% sodium hydroxide, or this is a pictorial loss, blood loss assessment chart, wherein you can see the lady always will tell you how much pad she has sewn, because this is a pictorial assessment in a patient who is not that intelligent enough to tell you how much loss is there. Or today we can have the menstrual club. I mean, if a lady says that usually one menstrual cup will hold about 10 to 15 cc. So number of menstrual cups which she has changed, that can also be useful in the diagnosis of the heavy menstrual bleeding as far as the adolescent are concerned. Now, if at all you see, we are not going to go to the structural causes. The non-structural causes are AUBE, and to come to a conclusion, there are various steps that we can come to a conclusion. One is, of course, the clinical assessment. Number 2 is the imaging. Number 3 is the biopsy. And number 4, the laboratory tests. So these are the mainstay when you come to the conclusion or diagnosis of exclusion of AUB. So thorough medical history. So medical history will include the patient's age, her menstrual history, marital history, history of any endocrine diseases, which Dr. Shama madam told in the earlier slide, history of any recent medication, and coagulation disorders. So coagulation disorders is a very important thing whenever you come to a case of AUB in the adolescence or in the menarcheal stage. Now, physical examination, of course, we have to look for signs of anemia, hypothyroidism, hyperthyroidism, polycystic ovaries, obesity, hirsutism, acne, and all that. And again, do a clinical examination and rule out vaginal, local, cervical causes or any other causes. And these are all the auxiliary examinations, which include a CBC, coagulation profile, pregnancy test, again, very important, pelvic ultrasound to rule out uterine lesions, and measurement of the BBT for, of course, follicle monitoring, and determination of the various hormonal tests. So these are all the conditions or all the steps which we need to take before we come to a diagnosis of abnormal uterine bleeding. So this is just a small history. In the personal history, one must look for smoking, alcohol, because these are very important thing. History of associated symptoms like pain during menses, again, chronic pelvic pain, which will give us some different diagnosis like endometriosis, and again, sexual and reproductive history. So this is appropriate history in women with AUB, and these are all the blood tests which we mentioned earlier. Of course, we don't jump directly to histoscopy, but as up to or endometrial sampling, because these are invasive, but all the other tests which are necessary can be done in all such cases. Okay, now there are when we come to the management approaches for AUBE, then we have the medical management and the surgical management. We are only going to discuss about the medical management. And when it comes to the medical management, these two are the mainstay of management of AUB. Medical management and hormonal, medical, non-steroid anti-inflammatory drugs and antifibrinolytics. And as far as the hormonal treatments are concerned, we can go to conjugated estrogen, combined oral contraceptive pills, or progesterone alone. So let's study one by one. So if at all we come to NSAIDs, now in a patient who has got unopposed estrogen action, there is increase in the thickness of the endometrium and vascularity. There is more infiltration of cytotoxic lymphocytes, and there is raise in the pro-inflammatory cytokines that with the synthesis of COX-2 and PGE2. So this is the rationale behind giving non-steroid anti-inflammatory drug. So this is the pathway. We all know that phospholipids are metabolized by two pathways, the cyclooxygenase pathway and the arachidonic acid pathway. This pathway is very important for those PGs who are listening. This is the pathway by which the NSAIDs are going to have action by blocking the arachidonic acid pathway and excess production of PGE2 and PGI2. And of course, this is the line of management is mefenamic acid. And please remember, the mefenamic acid has to be given in a dose of 1 gram 3 times a day. Many a times what happens is mefenamic acid is available in a dose of 500 milligram, and patients tend to take only 500 milligram 3 times a day. So they are afraid to take 2 tablets 3 times a day. So this is the most important thing that one must remember when we advise the patients to take this dose. Now coming to antifibrinolytic, usually mefenamic acid and fibrinolytics are given in a combination. But if at all you have to give only fibrinolytics, then tranexamic acid 650 milligram 3 times a day for 5 days is the actual dose. And in case there is an acute bleeding, then of course 10 milligram per kg body weight IV, maximum to dose of about 600 milligram that can be given as far as the antifibrinolytics are concerned. Now coming to the hormonal treatment, we understood that estrogen, that is conjugated estrogen, combined oral contraceptives, and progesterone. So conjugated estrogen, if we have to give, that is Premarin, we can give 25 milligram IV every 4 to 6 hours for 24 hours when there is an acute episode, followed by combined oral contraceptive pills. So acute episode is going to control the bleeding, and oral contraceptive pills will be given as a maintenance dose. You can also give COCs, that is estriol combination pill. We can stop by giving this pill 1 tablet 3 times a day for up to 7 days till the bleeding ceases, and then we can taper, that is 2 tablets 3 times a day. Initially, 1 tablet 3 times a day, followed by 1 tablet BD and OD, and then taper it. And once the dose is over, course is over, then the patient will have the withdrawal bleeding. So if at all you can see, there are various types of pills which are available. So how does this pill act? The estrogen is going to influence homeostasis by increasing the clotting factors, lowering the plasminogen, increasing the protein S levels, activating protein C resistance, and promoting platelet adhesions. So these are the various ways by which estrogen is going to cause reduction in the blood flow. So this is again a very important question that is usually asked in the vivas. Okay. Again, if at all we come to progesterone, we all know that giving progesterone is like doing a medical curettage, because progesterone is going to enhance the stromal matrix, going to give it a structural stability. It is going to deplete the estrogen receptor. It is going to reduce the synthesis of cells. It is going to reduce the vascularity of the endometrium, reduction in the plasminogen activator, decrease in the fibrinolytic activity, and suppression of the HPO axis. So these are all mechanisms by which the progesterones are going to act. Again, very important questions whenever for those PGs who are listening. So mechanism of yeah, I'll finish in 1 minute. So mechanism of action of progesterone. So these are the various mechanisms of action of progesterone. So these progesterone can be given, you can give metroxyprogesterone acetate 5 to 10 milligram daily for 12 to 14 days. In acute stage, you can of course load her with 10 milligram every 4 hourly, and then every 6 hourly, and then every 8 hourly for 3 days. So this is how you can give metroxyprogesterone. Now, levonorgestrel IU system will be approved for patients who have ideally finished their families and would like to have, along with the reduction in the menstrual blood flow, contraception also. So for them, of course, LNG IUS is a preferred line of management. Now, yeah, so this is this is the progesterones which can be given, norethistron acetate 5 to 10 milligram. And if at all we have to give estrogen, of course, estrogen is available in 25 milligram IV bottles, so that we can give as told to you earlier. Now, in case a patient with a heavy menstrual bleeding comes, then we can, of course, initially we have to rapidly assess the vital signs if she's hemodynamically stable or unstable. If she's stable, then hospitalization. If she's unstable, then hospitalization may be mandated if the hemoglobin is less than 7, if there is symptomatic anemia, or if the patient is hemodynamically unstable. And then, of course, you can give all these this line of treatment. And in rarest of rare situations, in such patients, you may have to resort to a therapeutic curettage. So one must remember these are the doses which are available for such patients. Again, if the patient is bleeding.
Sorry to interrupt you, sir.
Yeah, I'm done. This is the
Okay,
last
sir.
slide. If the patient is bleeding, that is, we are not finding any cause, then of course further investigations for coagulation disorders, sonography, etc. can be done. And as I mentioned earlier, suction curettage is the last response, is the last piece. Now, during the subsequent bleeding phase for such patients, you can give, of course, tranexamic acid, metroxyprogesterone acetate, and norethitron. And of course, we should not remember to start OC pills and oral iron therapy for 3 to 6 months, and dietary advice of such patients. So this is the line of management for adolescents who come to us with abnormal uterine bleeding. Again, thank you so much. Thank you so much for giving me an opportunity to present in front of you. Any questions, I'll be happy to answer them in the chat box, because I understand that the next speaker is waiting for the talk.
Thank you so much, Dr. Kiran, for excellent talk. Although this problem is really is an exclusion, because endometrial, we have to go for the malignant condition, the hyperplasia or atypia or without atypia, or it may be because of some hormonal disturbance, or maybe coagulopathy. So this area really needs proper investigation, and to find out whether there is no other cause, then we can go on the medical management of this treatment. Excellent.
Thank you.
Dr. Kiran, there is one question, like which IV preparation of estrogen is available? We all know that it's IV Premarin. Though it's not
We covered in his talk.
Abha, sorry to interrupt, but we don't have that much time. Let Kiran answer in the chat box.
Yeah, I will answer.
Okay,
I will
thank you.
answer in the chat box.
Okay.
So our next speaker is Dr. Abha Singh. She is a director, professor, and head of the Department of Gynae, Lady Hardinge Medical College. She is a vice chairperson, Safe Motherhood Committee, chairperson of PCPNDT Committee, and she's having lots of place. She is occupying co-chairperson of Safe Motherhood Committee, vice president of Delhi Gynecological Pass, honorable secretary of Study Gynae Delhi. And her field of interest is the high-risk pregnancy, laparoscopy, infertility. and she is my senior from MBBS. That is more important. Dr. Abha, she is going to speak on hormonal drugs and
Hello. कहाँ गया? Am I audible?
I'm audible or not?
Yes.
I'm audible.
Yes, madam. Yes.
Yes. So whatever I have, I think
Yeah, we heard everything.
Abha.
Yeah, we heard everything. Dr. Abba, you can start.
अरे मारा वो कहाँ चला गया? You are sharing. I don't know. Can you see the screen?
Yeah. Do it full screen.
Yeah.
There's some problem. This green thing is coming on the top. Shouldn't.
It's coming, but it's focus. I think the problem in
Hello.
focus.
I think it's okay now.
Yeah.
Okay. So, good afternoon, everybody. And first of all, I'd like to thank Dr. Parag Biniwale and Dr. Lakshmi Srikhande for giving me this opportunity. At present, I've superannuated from Lady Harding Medical College. I am working in ESI Medical College, Faridabad. So this is my latest thing, and this was the CV which I don't know was not presented. It was a very old CV. No problem. So abnormal uterine bleeding is, and Dr. Kukroti has made my task easier because he's already told all the drugs and everything. But okay, as a formality, I'll have to say iatrogenic. Abnormal uterine bleeding is defined as bleeding from the uterine corpus that is abnormal in duration, volume, frequency, or regularity. But here what happens, this bleeding may not be regular, and it may be just unscheduled bleeding in iatrogenic variety. And you all know AUB can be acute or it can be chronic. That is within 6 months or before 6 months. And this everybody has told. The importance of iatrogenic AUB is that it is caused by medical interventions, including medical medications, procedures, or devices used in patient care. And exogenous therapy may also lead to unscheduled endometrial bleeding. The significance is that 1 to 2% untreated anovulatory AUB may develop endometrial carcinoma. So we have to be really careful of all these patients. Then unnecessary and lead to unnecessary curetages, unnecessary hysterectomies. So proper workup and medical management is usually required. In the age group which is affected is adolescent, around 20%, between 40 and 50 years of age, around 50%, and in the reproductive age group, you find 30%. So it is a cause of concern. The causes of AUBI may be because of medications like hormonal agents, combined oral contraceptives, I'll not take the names, then hormonal intrauterine systems, then HRT, GnRH antagonists, then SERMs, selective estrogen receptor modulators like tamoxifen, this is a notorious one. Then non-hormonal medications like anticoagulants, antipsychotic drugs. Haloperidol is quite a bit used, and it may cause hyperprolactinemia. Then cytotoxic chemotherapy in the form of cyclophosphamide, corticosteroids, which may, the long-term use may cause suppression of HPO axis, and thyroid medications. All of these may lead to problems, abnormal uterine bleeding. Then intrauterine devices like copper Ts and hormonal IUCDs, LNG, also may lead to bleeding, but usually in the early period there may be just slight amount of bleeding or irregular bleeding, and by some treatment, giving OCP pills or by giving progesterones, this bleeding may be stopped. So it is really not very difficult. Then surgical or procedural intervention like endometrial ablation, dilatation and curettage. There may be incomplete evacuation or trauma may cause bleeding. Then cesarean section and the formation of a niche. This is also one of the causes these days, the formation of niche and cesarean scars. Then post-abortion interventions because of retained products. So Then again, there is radiation or chemotherapy. Pelvic radiation, again, it may lead to endometrial damage or atrophy and irregular bleeding. Chemotherapy can cause ovarian suppression, leads to estrogen deficiency, and again, the endometrial changes. Then other iatrogenic factors are pituitary suppression drugs like dopamine agonists, antagonists, then inappropriate or unmonitored HRT regimes. So these are the main causes of irregular or iatrogenic bleeding, abnormal uterine bleeding. And the mechanism is in hormonal contraceptives, you all know there may be endometrial instability, HPU axis suppression leading to irregular spotting or even amenorrhea. In anticoagulants or SSRIs, there may be impaired coagulation or platelet function, which may lead to heavy or prolonged menses. So the bleeding pattern will be different in different types of causes. IUDs, local endometrial inflammation or suppression, irregular bleeding and no irregular bleeding. Yeah. Then HRT, then procedures like which cause trauma to the endometrium and chemotherapy. Then in hormonal contraceptives, it may inhibit this combined oral contraceptives may inhibit ovulation, maintain a thin, unstable endometrium, and again the missed pills or low, which cause low estrogen, they may lead to poor endometrial stabilization, and there can be breakthrough bleeding. In progesterone-only pills, continuous progestations are given, which may lead to endometrial atrophy, because the estrogen primed endometrium is not there, estrogen to stabilize lining is not there, irregular bleeding can occur. Injectable progestins like DMPA, profound suppression of ovulation and estrogen may lead to endometrial atrophy, spotting, or amenorrhea. Then implants like nexaplanon, again, this is also progestin. It will also cause unstable endometrium and unpredictable bleeding. Hormonal IUDs, local levodostrel effect may be there. There may be glandular atrophy, desterilization, initial irregular bleeding, and then amenorrhea with long-term use. Then in emergency contraception, the cause may be disrupts the LH surge and ovulation, causes temporary endometrial disruption and intermenstrual bleeding. So we've covered all these things. I think I should not go into detail. The anticoagulants, I've already told you, it inhibits the coagulation pathways, impaired hemostasis, and leads to menorrhagia. Then antiplatelets, like aspirin, they impair the platelet aggregation, so there is prolonged or heavy bleeding. SSRIs, they inhibit serotonin reuptake in platelets, reduced aggregation and bleeding tendency. Tamoxifen is an estrogen agonist in endometrium, leads to hyperplasia and polyp formation, and irregular or postmenopausal bleeding may be present. Then corticosteroids, it suppresses the HPO axis, leads to anovulation and dysfunctional bleeding. The herbal agents or enzymes inducers, they increase the hepatic metabolism of contraceptive hormones and may lead to breakthrough bleeding. Hormonal replacement therapy, unopposed estrogens may stimulate endometrium proliferation, and without progesterone opposition, and will lead to hyperplasia, and again irregular bleeding will be there because of the shedding of this endometrium. Then sequential estrogen progesterone withdrawal induces scheduled bleeding. There may be irregular intake of these hormones not in a proper manner and may lead to unscheduled bleeding. Continuous combined HRT with continuous progesterone and estrogen will suppress the endometrial growth. Initially, there will be spotting and the lining will be thin. Then trauma, because of endometrial biopsy or curettage, mechanical trauma, hysteroscopy, polypectomy, myomectomy, cesarean section, I've told you that there can be poor healing and niche formation. So then enzyme induction in drug interactions because of antiepileptics. There may be, they induce cytochrome P450 enzymes, which decrease the steroid levels and which may lead to breakthrough bleeding and contraceptive failure. So evaluation is, everybody has discussed it. I don't think I should go into detail about the menstrual history, the amount of bleeding, the onset, the frequency, then drugs which the patient is taking, whether she is on hormonal contraceptives or anticoagulants. So the drug therapy has to be taken in detail. This is the pictorial representation. How much blood she is losing. So then you understand what is the exact type of bleeding or exact amount of bleeding and what treatment she requires. Then systemic illness like coagulopathies, endocrine disorders like thyroid and hyperprolactinemia should be taken care. Then liver and kidney dysfunction should also be taken into care, that patient is not having all these problems. Then examination, first the physical examination, general signs of anemia, thyroid examination, abdominal and pelvic examination, as you do in all patients, you have to do in these patients also. If the patient is having heavy bleeding, then you may omit it. You can give her some drugs and after that you can do examination. Otherwise, pelvic examination gives you a lot of findings, a lot of information. Then laboratory. Okay. So in laboratory investigations, the CBC, TSH, prolactin, urine for pregnancy test should be done in all the patients to rule out pregnancy. Then coagulation profile, then pelvic ultrasound. You have to look for endometrial thickness, structural abnormalities should be ruled out if the patient is having bleeding. Then IUD position, again, that may be one of the causes. Then endometrial evaluation has to be done. Endometrial biopsy should be done in all the women above 35 years of age because there may be risk of endometrial carcinoma. And these days you have people biopsy. So with that, you can do it as a OPD procedure also. And same thing in patients who are on tamoxifen therapy. Then if no organic or systemic pathology is found and the bleeding pattern coincides with the onset or change in a drug device, there's plausible pharmacological mechanisms, then you think that the diagnosis is iatrogenic AUP. So iatrogenic is a diagnosis of exclusion. Like Dr. Kukriti was also saying, this is also a diagnosis of exclusion. And treatment is hormonal contraceptives, which can, if you can give OCP pills, or initially you can add NSAIDs, and if the bleeding is stopped with this mefenamic acid, then it's okay. Otherwise, you can give tranexamic acid. Otherwise, you can start the patient on higher doses of OCP pills so that the endometrium gets stabilized. Then anticoagulants, you can coordinate with the prescribing physician to adjust the dose, and you can add tranexamic acid and hormonal therapy. You can give LNG IUS to control the bleeding. Monitor coagulation profile regularly. Then SERMs, they cause endometrial stimulation and formation of polyps and hyperplasia. So regular monitoring has to be done with ultrasound, endometrial biopsy if persistent or postmenopausal bleeding. Progestin therapy should be given because this is hyperplasia. You have to give progesterone to counteract the estrogen effect, and consider switching medications if possible. Then intrauterine devices like copper
Sorry to
IUD.
interrupt you, ma'am.
Just a moment.
Okay.
LNG IUS, again, reassurance, NSAIDs, and switch to, if you are using copper T, you can switch to LNG IUS, and you can give short-term OCP pills. Then other medications like psychotropic drugs, again, you have to consult the physician. Then procedure management, IUD can be removed. If it is because of intrauterine device, endometrial ablation and hysteroscopy can be done. General measures, you all know, iron therapy and hemoglobin has to be seen. The carry home messages, monitor and follow up the patient to ensure that the bleeding resolves or improves, reassess treatment adherence and response, and evaluate for other palm coin causes if the patient is not responsive. Special considerations are to rule out pregnancy and malignancy. Thank you.
Thank you, Dr. Abhay. Indeed, it was a very good talk on iatrogenic causes of AUB. And I think a good history taking is very important. And any iatrogenic bleeding in postmenopausal age should be taken seriously, and endometrial surveillance should be done for this. I think we should now move on to the next one. So thank you so much, Dr.
Thank you, Dr. Abba and Dr. Shampari. Thank you.
Thank you, Dr.
I request Dr. Abha Madam to introduce our next speaker, Dr. Viswajyoti Guha sir.
It's again my pleasure to introduce Dr. Viswajyoti Guha, who is a senior consultant obstetrician and gynecologist at Manipal Hospital, Mukundapur. He also works in Bhagirathi Newtia Women and Child Center, Newtown, Kolkata. He has been very active in RCOG and Vice President of Bengal Obstetric and Gynecological Society, member of Perinatology Committee, FOXY, and President ISOPAP Kolkata chapter. He has been the clinical examiner for MRCOG Part 3 and a peer reviewer for Jogi. I request Dr. Guha to please give his talk. I think this will be EIN, so he'll be talking on not yet classified, I think so. Not otherwise classified. So over to you, Dr. Viswajyoti Guha. You are muted, Dr. Guha. I think you should unmute yourself.
Thank you, Dr. Abarani Sinha, for your kind introduction. And at the very onset, I would like to thank Dr. Lakshmi Srikhande, Dr. Parag Viniwale, and Dr. Meena Saman for having me here to this very important certificate course, which I can see is very well attended. And what can I say about my chairpersons, Dr. Abarani Sinha? She is a very good friend of mine, and she comes from my neighboring state. Dr. Abhayankar is a renowned professor, and Dr. Jaiswal is also a renowned professor. So as Dr. Kuti was saying, that if you have any questions, direct to the professors and not to me. So we'll start on AUBN. Now, we know that what happens. So I always start with a small word of wisdom from Swami Vivekananda. Arise, awake, and stop not till the goal is reached. And what happens is in AUBN is something not otherwise classified is distressing to the doctor because he doesn't have, he or she is at his wit's end. He doesn't know what to do and how to treat the patient now because all has been excluded and nothing has been found. And it's very frustrating for the patient because she continues to bleed, she becomes anemic, and yet she does not know how far the treatment is. And most of them will end up having an unindicated hysterectomy. So Figo's palm coin classification was introduced in 2011, which was updated in 2018, and where N denotes causes not otherwise classified. And AUBN does not, if bleeding does not form into palm, as other mentioned today, and the COE, which categories, and so this is a different category at present that we are discussing. And the main conditions that causes a non-specified, not specified due to uterine bleeding is uterine venous malformations. I'm sure that you have experienced many of them in your current practice, and you do so regularly in your clinics. Chronic endometritis, pseudoaneurysms, and myometrial hypertrophy falls under not classified categories. So what about AVMs? Dr. Vinit was very eagerly say, Parag told at the very onset, you must finish your talk very quickly. So we will not have, ponder upon very less important things. So AVM is abnormal artery venous connections bypassing capillaries. There is a fragile needles, and what happens is this fragile needles gives away, and there is an increased risk of bleeding. It is rare. Less than 100 cases have been reported, life-threatening when there is severe bleeding. Now, arteriovenous malformation it can also be iatrogenic, which we will come a little bit, as we go on to the top. It is found as strong vascular channels from direct hemorrhagic sources. So that is why these kind of bleedings are quite distressing to the patient, and to the gynecologist, because they try tranexamic acid. Sometimes it works, sometimes it does not. They try progesterone, sometimes it works and sometimes it does not. And then they are at their wits' end that what we can do next. And etiology is congenital. Sometimes there is an embryologic vascular developmental anomaly, and acquired, which is more common, and that occurs after uterine trauma, such as a dilatation and curettage, that we almost the most common operations that we do in gynecology. And after cesarean section, sometimes it does happen. And of course, curettage and tumors and infections. Now, DNC is one of the things, especially in 3 or 4 cases that I have seen in my practice, are all from DNC following, following retained products of conception or a miscarriage, and that can result in this kind of life-threatening hemorrhage. So epidemiology and presentation, uncommon, but maybe underdiagnosed. Sometimes we actually do not find out the cause. What happens is that this patient goes on bleeding, and we try and give them all sorts of treatments that we have had. We give them progesterone, some will give them estrogens, IV estrogens if possible, but still this bleeding does not stop. And then the last resort is hysterectomy, and I have seen women undergoing hysterectomy at the age of 32 to 33 because of undiagnosed abnormal uterine bleeding. And patients in reproductive age group with AUB and postpartum hemorrhage can also be one of the causes. So clinical features are heavy recurrent bleeding, intermittent hemorrhage, and especially when you do a Doppler study, you will find audibly turbulent flow on Doppler. These patients are usually stable, with vital signs are usually stable until they severely bleed. So that is one of the problems that we face, because that is the reason why we tend to underdiagnose these kind of conditions, because we are not aware of these conditions unless they bleed severely and they become hemodynamically unstable. So what about diagnosis? The main diagnostic background is imaging, which is a transvaginal ultrasound, which together with a 2-dimensional Doppler may show a high velocity, low resistance flow, or a color mosaic pattern, which is diagnostic of arteriovenous malformations. And advanced imaging, of course, if you suspect that you have got a AV malformation, some of the ultrasonographists are very good. They will say, this looks like an AG malformation. Please do a CT angio to confirm. And whenever we do a CT angio, the CT angio are almost diagnostic of arteriovenous malformations, and they easily can delineate the needers, the feeders, and drainers, and we will come to the treatment later. And that is by doing a CT angio is how we treat this kind of arteriovenous malformations. And digital subtraction angiography is also a diagnostic as well as therapeutic, because with this we can actually treat arteriovenous malformations. So diagnostic cautions. One of the things that we always say to our juniors or our trainees, that you must not do too much of curettage. A gentle curettage is the best, because if you do too much of sharp curettage, it can damage the uterus, and that may provoke massive hemorrhage. Proper imaging technique of AUB before blind procedures if AVM suspected. So if you suspect AVM and if you are doing a curettage, if you do a very sharp curettage, then there is a chance that you are going to injure that needles, and she will start bleeding profusely on the theater, and your pulse rate will go high, our pulse rate will go high, and the anesthetist pulse rate will be racing as well. So management options overview: conservative, medical, that is embolization. That what we do normally is uterine artery embolization or selective embolization of that bleeding vessel. That is what our radiologic, our intravenous radiologic colleagues do. They usually put a gel or some kind of a foam in the offending artery, and the bleeding stops. And of course, there is surgery which can be done, hysterectomy, which can be done laparoscopically as well. or by open one. And conservative management observation if asymptomatic. So you can observe them and give them some GNR channel rocks plus aromatase inhibitors and tranexamic acid, which if there is no bleeding can swing the ABM over a 6 months period. It is rare to happen, but it can happen. And this is something that we can look forward to. And of course, uterine artery embolization is the first line for treatment of life-threatening hemorrhage, fertility preserving. We know that after uterine embolization, there is reported cases of pregnancy, and there is a success of 90% in stabilizing the baby. And of course, if UAE fails, then laparoscopic excision, ligation, hysteroscopic resection, or hysterectomy can be done. So what about fertility preservation? Many treatments are fertility sparing, such as UAE, the GnRH therapy, and cases of successful pregnancy post-treatment are also noted. Follow-up is very important. We do a post-treatment follow-up by Doppler or MR if essential. Lower PSV and HB predict conservative success. High Doppler for these patients need close monitoring. RCOG advises use of the LNG IUS devices. First line for idiopathic AUB with contraceptive needs. But this is something we have to do with caution because sometimes it does not help and it confuses your diagnosis. And AUBN, the other one is chronic endometritis, which is characterized by endometrial inflammation with pus cells causing abnormal uterine bleeding, persistent microbial endogenous infection, stromal and plasma cell infiltration, cyclic edema, and vascular changes. And 4 to 12% is the incidence rate. Risk is DNC, IUD insertion, postpartum events, miscarriage, and pelvic inflammatory disease. And clinical features are often asymptomatic or mildly symptoms such as spotting, mild pelvic dysfunction, abnormal uterine bleeding, and the prevalence is almost 10% in endometrial biopsies taken for abnormal uterine bleeding. And the diagnostic strategies are hysteroscopic, mainly show signs of stromal edema, some micropolyps, hyperemia, which can be confirmed by directed biopsies. And on histopathology, we'll find detection of plasma cells. CD138 is in the stroma is gold standard. And RCOG always, goes ahead and say offer hysteroscopy with directed biopsy when there is a persistent intermenstrual irregular bleeding occurs. And management targeted antibiotic therapy based on culture or presumed pathogens. Example, common one is doxycycline, and it can result in resolution and of inflammation and improvement of bleeding pattern. And our Royal College suggests in suspected endometrial cause of AUB, after exclusion of PAM, COE, manage medically first. Outcomes and follow-ups, post-antibiotic expect rapid symptom relief and normalization of bleeding, repair hysteroscopy and biopsy if symptom persists, address any underlying risk factors such as IUD removal, or treat PID, or careful with uterine artery instrumentation. So take-home points, AUBN is a diagnosis of exclusion, and most of the AUB are actually. It requires history or investigation and appropriate measures to arrive at a diagnosis. Important to rule out endometrial hyperplasia and malignancy in high-risk groups, individualized management, that is personalized care based on age, reproductive desire, severity of bleeding, and patient preferences. Follow-up at regular intervals is the key in the successful management of AUB. With this, thank you very much for inviting me today for this talk.
Thank you, Dr. Guha. Indeed, it was a very good presentation where you gave overview of not otherwise classified causes of AUB. And you have very rightly said that for AV fistula in a young women, the cases that we have seen are DNC cases. After DNC, when the patient is bleeding irregularly, it was easy to diagnose. But now with Doppler, I think we are getting more and more cases. And of course, uterine artery embolization, if the patient wants fertility, should be the first treatment of choice. And infection, I think that, especially in our context, in our country, I think that should be one of the cause which should be considered and should be treated when PAM COE is excluded. So thank you so much. It was a nice presentation. And I would also take this moment to thank Dr. Parag Biniwale, Dr. Lakshmi Shikhande, Dr. Meena Samant, and the whole ICOG team for inviting me to be a part of this wonderful FOXY ICOG certification course. Thank you.
Thank you very much. Thank you.
That we come to the end of the scientific deliberations. But Shama madam is saying something. Ma'am, we can't hear you. Ma'am, Jaiswar, ma'am, we cannot hear you.
Hello, hello.
Yes, yes.
Yes, it is okay. Hello.
Yes.
Yes. So this just I wanted to add that sometimes we are doing DNC and the patient is bleeding so much in case of AV malformation which is not diagnosed prior. In that we have to put the police or tampon to stop the bleeding. But if it is already diagnosed case, in that we can go for the conservative like embolization. So that is the good alternative. And in case of endometritis, if the patient is not responding, sometimes endometrial tuberculosis is very important because the genital tuberculosis can cause chronic endometritis which does not respond to any antibiotic. So that it should also be considered. Otherwise, thank you so much. And I thank Dr. Lakshmi and Dr. Parag Biniwale for giving this opportunity to share this platform. Thank you so much. And my
Thank
best
you,
wishes
Meena.
to you.
Thank you, Meena ji.
And thank you, Dr. Meena.
Thank you, Dr. Meena. Thank you very much.
I think, Dr. Vishwaji, you shouldn't leave before answering the questions in the chat box. But we have one very important responsibility, and that is the post test. So I think we have a lot of people logged in. Go ahead with that.
Shreya, please post link in the chat box.
Yes.
Delegates, please pay attention. We are posting the, link is already posted. We will be starting the timer. Click on the link and start answering.
With 15 minutes. last 3 minutes, but I guess most of them have finished. Please put the link. Thank you everyone for participating in the post-test. I guess all of you have finished. There was enough time. Some were latecomers as well. So I think first we'll go through the answers first. We can check for ourselves how much we have scored. So the first question, the most common symptom for endometrial polyp is intermenstrual bleeding. The best diagnostic method for endometrial polyp is hysteroscopy. C. AUB-A, that is adenomyosis, is best diagnosed by, answer is C, TVS with MRI correlations. Fibroid location most commonly associated with AUB is answer B, submucosal. Gold standard imaging for fibroid mapping is C, MRI. And preferred surgical treatment for FIGO type 0 fibroid is B, that is hysteroscopy myomectomy. Risk factor for endometrial hyperplasia is obesity, C. And simple hyperplasia without atypia is best treated with answer is C, that is progestins. AUBC, that is coagulopathy, most commonly is due to answer is B, von Willebrand's disease. Diagnostic test for von Willebrand's disease is answer C, that is von Willebrand antigen assay. And preferred initial treatment of AUBC in adolescents is answer B, antifibrinolytics. Long-term risk associated with chronic anovulation is answer C, that is endometrial hyperplasia. And AUBE is defined as answer is B, endometrial dysfunction with structural or hormonal, without structural or hormonal cause. And which is the treatment option for AUBE? Answer is A, LNGIS. Common nitrogenic agent causing AUB are all except answer is D, that is levothyroxine. And LNG-IUS helps in AUP by answer is B, that is endometrial thinning. And chronic endometritis associated is associated with answer B, that is infertility and recurrent pregnancy loss. AVM is a cause for AUP, best diagnosed by answer B, Doppler ultrasound. And best initial management of a diagnosed uterine AVM is answer B, embolization. And most common cause for AOBM that is not classified is answer A, that is chronic endometritis. So that's it.
Yeah, thank you, Meena. And on behalf of the organizers, let me appreciate Dr. Meena Samant, Dr. Lakshmi, who are sitting here for last 3 hours plus, and they've been doing that since yesterday. Suyoga, thank you very much for being the MOC. Despite of the fact that 2 of your colleagues couldn't join in, you managed to stay back for the last 3 hours and did a good job. Thank you to all the speakers, Pragya, Parikshit, Damodar, Achla, Aswat, Shama, Kiran, Abha, and Biswajyoti. Special appreciation to Kiran and Biswajyoti because their topics were probably the most difficult. And I'm sure Lakshmi will also agree because these are the 2 situations, AUB-E and AUB-N, where we are really clueless, and talking about this is really difficult, but both of them did full justice to our presentation. So thank you all the chairpersons for sparing your valuable time for ICOG, and we'll see you all again tomorrow for the last day of this certificate course. And please don't forget that the next month's certificate course is on adolescent health, which will be last Wednesday, Thursday, and Friday of August. So stay tuned and we'll see you all tomorrow. Thank you. Meena, a word from you.
Just finally, as a convener of today's session, I must thank Dr. Parag Iniwale, chairperson of ICOG, who's been the staunch support, very committed person, because our own President Foxy, very dynamic, there's a mission and vision. And of course, Dr. Lakshmi Shrinkandi Madam, she's been there and guiding everyone. A very great leader, I must say. My thanks to, of course, our coordinator for today, Dr. Pannat. She did it alone throughout. And then, of course, a very learned speakers who were so updated. And, really, we had a lot to learn. I'll just name them once again, Dr. Pragya Mishra Chaudhary, Dr. Parikshit, Dr. Damodar Rao, Dr. Achla Batra, Dr. Ashwat Kumar, Dr. Shama Kedar, Dr. Kiran Karkoti, Dr. Abha Singh, Dr. Vishwajit. All of them were so fantastic. And of course, our very revered chairpersons, Dr. Ashok Kumar Udani, Dr. Lakshmi, Dr. Tarani Taneja, Dr. Mala Srivastav, Dr. R.K. Purohit, Dr. Sunita Wadhwani, Dr. Abha Rani Sana, Dr. Bharti Abhyankar, Dr. S.P. Jaiswal. Of course, a hearty thanks to all our viewers who've been there, logged in, and for attempting. And I think you all had a great time today. And thank you once again, Dr. colleague, our secretary, and Dr. Lakshmi Madam for also the opportunity given to us as well. Thank you. I think we call it a day now.
Yes.
Yes, thank you.
Thank you. Bye.
Good
See you all
night.
tomorrow at 4 p.m. Bye.
Bye.